Address. Please settle down. I request Professor Patel to kindly take over the keynote address, which is titled Reimagining India's Health System.
Okay. Good, good afternoon. Good morning, everyone. I'm just going to. Okay, let me start. Let me first of all just start by repeating what I said a few moments ago about what a privilege and honor it is for me to be addressing you all at this conference today. As I mentioned, the question of the theme of this conference, the importance of ethics, dignity, and values in healthcare is one that is critically important to each and every one of us, because each and every one of us at some point in our life, and in fact for some of us unfortunately at many points in our lives, will be interacting with the healthcare system, either alone for our own needs or for the needs of our friends and family members. Now, in my opening remarks, I'm going to draw on two very different strands of work that I have been involved with over the last many years of my life. The first is the work that I have been leading in the Lancet Commission on a citizen-centered health system for India, a piece of work that began in December 2020 and reached its culmination with the publication of the report in the presence of the editor-in-chief of the Lancet in New Delhi on January the 21st. It was a very important event with strong participation from the Niti Aayog and several other scholars and policymakers from around the country. The Commission had one very central and powerful premise, that the people of India must be at the center of how we design, finance, govern, and deliver healthcare. The second theme is my 30-year-old innings with Sangat, one of the co-hosts of this important conference. Sangat, as I always very proudly say, is a Goan NGO which has an impact not just in Goa, but around this country and indeed around the world. It's an NGO that had a very humble start back in 1996, as I mentioned, in a one-bedroom apartment in Polvaram, but which has subsequently pioneered innovative ways in how we can leverage community resources, most importantly, people in the community, you and me, to help prevent and to care for people who are living with mental health problems. The science that Sangat has generated has transformed not only India's national mental health policy, but of course back home here in Goa, transformed how the Goa government delivers mental health care, but indeed is now transforming mental health policy and programs across the world. But more importantly, and to the theme of this conference, I will draw upon Sangat's work to demonstrate how ethics, values, and dignity lie at the heart of what we do when we do mental health care. Let me now turn to the first strand of this work, the Lancet Commission. The Lancet, for those of you who are not aware or not from the healthcare world, it's worthwhile me just mentioning a little bit about that medical journal. The Lancet is more than a 200-year-old medical journal. Interestingly, a little bit of a historical snippet. It was started by Sir Thomas Wackley in London, and in the founding mission of the Lancet, he actually declared that the reason why he had started the journal was because there was so much corruption, lack of ethics, and lack of dignity that people in Britain back in the 19th century experienced when they accessed healthcare. I thought it was very, very precise to the point of this particular conference. So the Lancet is the world's leading medical journal, and it has never ever published a whole commission that has been devoted to India. And so this was a very important scholarly event, apart from what we hope will become an important policy event as well. We launched this commission in December 2020. This was exactly at the end of the first year of the COVID pandemic. Many of us would like to forget that there was a pandemic. Many of us have in fact forgotten that there was a pandemic. The truth is, it was only 5 or 6 years ago. And it's an incredible period for all our lives, and I don't think we should ever forget that pandemic, because it affected us in different ways, but it affected most people in some way. Remember, December 2020, things didn't look so bad in India. But just a few months later, the Delta wave devastated our country, including right here in Goa. It ripped through communities around the country, and the latest data that have come from the Government of India on mortality clearly demonstrate that upwards of 1 million people died in the space of a few months, making this the single most devastating event to hit this country since independence in terms of health outcomes. So the pandemic reminded us in a very stark way of the vulnerabilities and the risks that we were taking when we have a weak healthcare system. But yet, on the other hand, it also reminded us of the deep wells of resilience and the deep resources that this country has. And it's important to acknowledge that. We saw in the space of a few months the country's tremendous industrial and technological infrastructure design, manufacture, and deliver vaccines at an unprecedented scale. And for this, I have to acknowledge two very different kinds of resources that India has developed over the last 50 years. The first is the indomitable community health worker. The one area that I have spoken to our health minister is the greatest regret that Goa is the only state in India that actually does not have a community health worker, whom we call the ASHA. Every single other state in the country has an ASHA for historical reasons, including the fact that we already have a pretty strong public healthcare system. Goa eschewed having an ASHA. But the ASHA is, in my view, the single most potent human resource for health in this country. It's not the oncologist, it's not the cardiologist, it's the humble woman from the village who visits every household in her community and provides frontline promotive and preventive health care. And it is her central role in the vaccination program during the pandemic that led in 2022 the Director General of the World Health Organization to award all million ASHAs collectively the annual Director General's Global Health Leaders Award in 2022. Let me tell you, no other Indian has ever received this award. But at the same time, you have on the one hand this innovation of the ASHA doing this incredible grassroots community work. On the other hand, you have the most sophisticated technology. A technology platform that was then called CoWIN. All of you will remember this, because all of you will remember, like I do so vividly, having to actually book our vaccination appointments. For me, it was at GMC as a doctor. I was given some priority. And I remember everything was done on an app. That platform was designed in a matter of a few months. And it is a great reminder not only about the deep technological resources our country has, but about the spirit of partnership, because that entire platform was designed for free by the Bangalore technology ecosystem and was then deployed by the Government of India to deliver the vaccine, like I said, on an unprecedented scale. And today, that very same CoWIN platform has evolved into the backbone of India's most ambitious digital public infrastructure, which is, of course, the Ayushman Bharat digital mission. Friends, it's important when we think about healthcare in India to take a little shortcut of history that I'm going to do for you. Our journey to universal healthcare, or universal health coverage to be more accurate, actually began around the time when we were becoming an independent nation in 1947. A few years before independence, the British Raj had set up what was called the Bohr Committee. At the same time, there was a similar committee that Britain had set up for its own healthcare system, which was as deeply dysfunctional as India's healthcare system was back in the the early part of the last century. That committee was called the Beveridge Committee. So you had the Beveridge Committee in Britain and you had the Bohr Committee that was for India, that was intended to design a person or a people-centered healthcare system for both countries. Unfortunately for our country, 200 years of avaricious British loot had meant that the Bohr Committee report could never be implemented. The Bohr Committee had actually stood for a strong public healthcare system grounded in primary healthcare and community empowerment. On the other hand, in Britain, the Beveridge Committee report, which was introduced after the Second World War was won, was fully embraced by the government, and thus was born the National Health Service, something which many people like myself who have worked and trained in the National Health Service would regard as perhaps the best example of universal health coverage in the world. Such an interesting historical point. Two countries that were at one time joined by colonialism, one developed an incredibly socially determined healthcare system, and the other one, because it had been looted by that country, had no money to do the same thing. So instead, the bankrupt Indian government, we were not just bankrupt in terms of money, but the British had also left us with virtually no human resources for health. We had barely any doctors. Our clinics did not reach beyond the cities. The overwhelming majority of Indians relied on folk remedies and on one another when they fell sick. So perhaps it's not surprising that when the new Indian government was trying to build a healthcare system, it naturally focused on access. It naturally focused on building capabilities such as doctors, medicines, nurses, buildings, because this was completely absent when the British left. And so this doctor focus and this very narrow medical focus, and then a focus on very specific health programs. So you had the birth of all the national vertical programs, programs for malaria, programs for TB, programs for family planning, etc. And ultimately this led to a very fragmented, disease-centric, doctor-focused model of healthcare. This was never what the Bohr Committee report called for. But it was what we could afford, and in hindsight, it may look like not a great decision, but at the time, it was the only thing that we could actually implement for our people. The real transformation happened in the early 2000s under the Manmohan Singh government as economic growth and development allowed the government to start embracing a much more universal health approach. And it is around that time, with the birth of the National Rural Health Mission, that you see the birth of the ASHA. The community health worker that I mentioned has now become emblematic of India's innovation in human resources of health. We also witness the development of primary healthcare. Today, Goa probably has the best primary healthcare system in the country. But the origins really go to the early 2000s when primary healthcare became the foundation of healthcare. And very importantly, the engagement of citizens. Over the last 25 years, we have seen the growth of civil society as an active partner in healthcare in a way that is uniquely an Indian idea. So at this moment in our history, we are at a pivotal point in our journey towards universal health coverage, which, as the Prime Minister himself has stated, is at the heart of his vision of Viksit Bharat. Marking 100 years of independence in 2047, he believes that we should be a developed country, and universal health coverage has to be central to being a developed country. With the exception of the United States, no other country that has become developed has done so without universal health coverage. And I can tell you, working in the US right now, that it is the worst example of a healthcare system, and it is the one that we have to resist and fear that it does not become the healthcare system of our country. I believe that with strong political will and steady economic growth, there's a real opportunity for India to leap forward to a health system that is truly universal. Now, turning to the work of the Commission itself, realizing a citizen-centered health system for India, a country of diverse ethnicities and languages, a country that I consider, having lived and worked on every continent in the world, I can tell you, I have never been prouder about one aspect of India that really is unique to our country, and it is our astonishing, astonishing diversity. But when you're trying to do something for such an astonishingly diverse land with such a formidable range of ecosystems, for health, one has to therefore engage with a very diverse group of actors. So when I set up this commission along with 3 other co-chairs, and I would like to just mention them to illustrate the diversity, we decided we needed a strong private as well as a strong public presence on the commission, because in India, healthcare has always been provided by both sectors. And so my fellow co-chairs were a colleague professor at the Harvard Business School, and Kiran Mazumdar-Shaw, who is one of the leading biotechnology entrepreneurs from Bangalore. And the 4th co-chair was Dr. Gagandeep Kang, who, like me, is an academic from a medical school, who happened also to be leading India's COVID response at the time. And together we brought together 20 commissioners drawing on civil society, the private sector, such as the head of Narayan Hridayalaya, Dr. Devi Shetty, amongst many, many others. 20 of us sat together and then started doing research for the last 5 years to understand better what are the challenges that are facing India's healthcare system. We organize our work into many different pillars of universal health coverage: human resources, for example, financing, technology, and so on. And each of these groups developed a set of research questions. And then over several years, with support entirely from Indian philanthropy, such as the Infosys Foundation, we started conducting this research. In a very brief, I'll give you an example of the scale of our ambition. We conducted the Citizen Survey, which is a survey of 50,000 randomly selected households from across this country to understand better people's utilization, their experiences, and their preferences towards healthcare. We developed with IIM Bangalore a brand new indicator that can help district-level assessment of progress towards universal health coverage. This particular indicator has now been adopted by the World Health Organization and will soon become the way we actually monitor how is North Goa doing, how is South Goa doing, how is it doing over time, etc., etc. We undertook the most comprehensive analysis of India's legal landscape from 1947, including our constitution, to understand what are the rights and entitlements, but equally what are the duties and responsibilities of our citizens towards healthcare, and so on. I'm not going to go into lots more research was done. Now, ultimately, what I'd say is that we assembled the largest comprehensive set of data that helps us understand what works and what are the challenges that India's health system faced. So I'm sure all of you want to know, what did this huge amount of work show? And in a nutshell, I'm going to give you the main message. India has made remarkable, unimaginably remarkable progress, particularly since the year 2000 in its mission to achieve universal health coverage. What are some of the key indicators of this? Today, friends, no political party, regardless of its ideology, will contest the idea that healthcare is a fundamental right of the people of India, and the government has to play a strong role as a financier, as a provider, and as a steward of the health system. Let me tell you, that's a really important thing, because most of our political parties don't agree on many things. But if there's one thing they agree on, is on the central role of education and health and the importance of the public sector. Today, as a consequence of that cross-party consensus, the health sector is the largest public operation in the world, with not just 1 million+ community health workers, but hundreds of thousands of other health workers working in an architecture that is unparalleled, all the way from the ASHA visiting your home, except in Goa, from the ASHA visiting your home, through to sub-centers, primary centers, block hospitals, sub-district hospitals, district hospitals, and all the way through to some of the world's most sophisticated tertiary care centers, all run on the back of our taxes. The country is the world's factory of human resources for healthcare. Not only supplying, we are not short of any more, unlike 1947. We're not short of any specialty, not short of any form of medical qualification. Yes, there are some areas where we are short, but generally speaking, we are the best producer of human resources for healthcare. We are producing enough medicines and vaccines, not only for our own people, but for the people of many other countries. And the technology sector is unbelievable in terms of the remarkable progress it's making to empower citizens, practitioners, and a health system as a whole. Just last week, there was a huge AI summit. Yes, it was last week. The big AI summit in Delhi was a great place in which some of our AI prowess was being showcased. And in my own prediction, coming from one of the world's medical schools that is at the top of AI right now, it's generally acknowledged that after China and the US, India really will be and already is positioning itself as the third major pillar of the AI economy. And I must also say, the spirit of our hosting that AI summit really speaks to what I think is our greatest strength, the idea that these are public goods. I think this was such an important message from our government that AI cannot be a good that is controlled by 3 or 4 companies in the United States, but in fact, it should be a public good that each and every one of us should own equally. Today, as a citizen survey showed, people have no difficulty accessing healthcare. Even in some of the poorest states of India, like Bihar, everybody, when they needed to see a doctor, they could find it, either in the private or in the public, and very often in both sectors. And out-of-pocket expenditure, which is one of the most important indicators of universal health coverage, something that all of us get affected by, how much money am I spending? Even though it is still amongst the highest in the world, it has been showing a very good decline over the last 2 decades. So friends, what is the problem? The problem is no longer access. Our government over 80 years has fixed that problem. And we should take full pride in that. And we should acknowledge that that has happened. Our forefathers had virtually no healthcare available to them. That is not the case today. We have enough doctors, we have enough drugs, we have enough diagnostics, and we have enough delivery centers. The real problem now is the quality of each of those. And I think it's important for us just to pause and think about this. The question of quality is one that actually affects every aspect of the state. It's not just in healthcare. And I'll give you one good metaphor for this so you'll understand what I mean. Let's take education as an example. The 2 big pillars of a healthy society, healthcare and education. Back in 1947, 80% of our country was illiterate, thanks, of course, to 200 years of the Raj. It isn't surprising then that when 80% of your country is illiterate and most children do not even go to primary school, forget about secondary school, any government's first focus is to build schools and to train teachers. Forget about quality. We want to have children in school. The same metaphor applies to health. Essentially, you had to build, train, and now we're at the same juncture in health and education. We have 100% enrollment in primary school. The tragedy is half our kids aren't learning anything. And in the same way, you see the metaphor that we have now 100% access to healthcare, but look at the problem of quality of healthcare. And this links very closely to the theme of the conference. We show in the Lancet Commission that in 2018, nearly 2 million Indians died. 2 million died because of poor quality healthcare. That is to say, healthcare, because it was poor in quality, basically killed them. Incredibly, this number is twice the number of people who died in the same year because they could not get to healthcare. What a shocking figure this is. This was also actually reported in the Economic Survey of India, that more people died as a consequence of bad quality healthcare, they're not actually getting to healthcare. And of course, even if you leave aside these numbers, not a day goes by when our newspapers don't remind us of how bad quality healthcare kills our people, from poison cough syrup all the way through to oxygen running out in a district hospital. Every aspect of our system currently is riddled with quality issues, from our training of doctors all the way through to the quality of care that we provide. And I want to touch on two themes that are very relevant to this conference. The first pertains to the theme of ethics and values. In the Commission, we document a large body of evidence that is examining the competence of doctors. The competence of doctors who are for diagnosis and treatment of common conditions like tuberculosis, for example. It is shocking what you will find if you look at the report. And by the way, the report is not, we haven't made up these data. These are data collected by numerous research groups around the country. It is absolutely shocking how low the competence of the average doctor is in both diagnosis and treatment. And the consequence of this is what? It's one of the world's highest rates of irrational and unnecessary prescription of medicines and diagnostic tests. Now, why should this be of concern to us? This is of concern to us because of every 100 rupees that an Indian is spending on healthcare, take a guess. How much of that 100 rupees that you're spending out of pocket is on medicines and drugs? Just some guesses. Let me just hear what people think. For every 100 rupees that you are directly spending out of pocket for when you fall sick, how much do you think goes on medicines and blood tests and x-rays and things that come? You'll see thousands of pharmacies. In fact, the single most visible presence of healthcare in India is the pharmacy. You can go to the smallest village in this country and you will see a pharmacy. Have you ever paused to ask yourself, you never see so many pharmacies anywhere else in the world. So why are there so many pharmacies in India? Does anyone want to make a guess on how much out of 100 rupees we spend is on medicines and diagnostics? Out of every 100, how much? What proportion? 80%? Yeah. Can you imagine? It's not on doctors' fees. It's not, because we often think the doctor is charging so much. Actually, the doctor's fees is a very small amount. It's what we're spending in our pharmacies and what we're spending in all the x-ray and blood labs. This accounts for roughly 70% of every rupee on healthcare that is out of pocket. Now, apart from this being, of course, a big driver of out-of-pocket expenditure, which impoverishes us, there is a more important threat. This irrational use of medicine is the single most important reason for the emergence of microbes that are resistant to antibiotics. This is not only threatening your economic well-being, it's threatening the public health of our country, and indeed, bugs don't know boundaries, they don't need visas. They will ultimately threaten the health of the entire world. Now, obviously, the first question that should come to our mind is, why are we the capital of irrational drug prescription? One key reason is this massive production of doctors from, I have to tell you, some of the least quality medical schools around the country that have mushroomed in the last few decades. And so these doctors are simply getting very poor training. And they come out of medical school simply not being adequately competent to diagnose and treat correctly. But the second reason is corruption. And colleagues of mine have documented very clearly the deep roots the pharmaceutical industry has on prescription behavior. And that, of course, means that doctors are prescribing not because necessarily the patient needs a medicine, but because there are misaligned incentives. So who pays the price? You and I pay the price. We pay the price both directly because of the money we spend on healthcare, but also ultimately it also affects our health outcomes. Now, some of my colleagues would say that healthcare is an industry and this is a transaction. It's an industry. People are coming, getting a service, and they have to make their own decision on whether the service is good or not. I fundamentally disagree that healthcare is an industry. I disagree because unlike buying a car or buying a fridge or going to your Kirana store, there is no real consumer choice in healthcare. The reason is we typically seek healthcare when we're in a crisis. It's very hard for us to judge quality. You know, there is nowhere you can go on an app and say, what is Dr. Vikram like? As you can look on an app to say, should I buy a Creta or should I buy some other car? There is no such place where I can get impartial information, unbiased information. This is not similar to any other industry. Then there is a huge asymmetry of power and information. When I'm sick, even though I'm a physician, when I am sick, I become an ordinary patient. And my doctor is close to God. I grew up in a society, we all grew up in the same society where we worship our physicians. So who is going to question that physician who says you need these 15 blood tests or 20 x-rays? You're just going to say he's doing it for my best interest. And so it's not an industry. Treating healthcare as an industry commodifies what is a basic human need. It undermines equity, and I believe it conflicts with a professional's ethical duty to prioritize patients over profits. And this is precisely why I believe the medical profession must rise above all other professions and stop claiming that we are members of an industry and instead commit ourselves to being members of a service-driven profession that champions ethics and values. If we don't do this, I want to just digress a little bit about why I mentioned earlier the US healthcare system is the worst, the one we should absolutely stay away from, is the opioid crisis as something most of you will not have heard of, so I will want to spend a few minutes to tell you what a catastrophe has enveloped the United States over the last 20 years. This is a catastrophe that is completely man-made. But the result is that the United States today is the only rich country in the world where life expectancy has actually fallen in the last 2 decades. And it has fallen because of a man-made health catastrophe. And that is the opioid crisis. The opioid crisis is a crisis that demonstrates how corruption can affect every single component of society if you consider healthcare purely as a commodity, which is what the US does. It is a crisis that occurred because pharmaceutical companies lobbied legislators whose elections they were financing. Those legislators then got the government to agree that pain relief was what they called a vital sign, like fever. And, of course, coincidentally, those companies were selling a new painkiller, which happened to be extremely addictive because it was built around the opiate molecule. It corrupted the entire medical profession to start prescribing opiates to 5-year-old children who had a toothache, and generated the largest drug-addicted population in US history. And by the time the government woke up and started seeing people die because of the opiate addiction and started closing down access to opiates, it opened the doors to the drug mafia from Mexico. But make no mistake, the Mexicans did not create the opiate need. The US House of Congress, in collusion with the medical profession and the pharmaceutical industry, created this catastrophe. There's a lot of great books about this. Dopesick, Empire of Pain, and others is a great example. And the reason I bring this up is, make no mistake, the moment you treat healthcare as an industry, it is inevitable that you're going to get these kinds of disasters. The second finding I want to draw on is that on dignity. The quality of care is very much worse for people according to their personal identities. And particularly people who come from poorer or communities that are considered outsider. And that's an important word for us in Goa, outsider, because I myself have been called an outsider, no longer because now I speak Konkani and because I lived here for long enough. But let me just say, for many of our poorest migrants, being an outsider is a stigma. I have a couple of a Bengali couple who work on my property in Peña de Franca, and I remember many years ago when they fell ill, I said, you should go to Goa Medical College. In my view, it's the best medical institution in the state. And I have to say, again, kudos to the Goa government for creating what is by far the best state-run medical institution, I think, in probably the country as well. And so, what they told me, they said, your experience when you go there is very different. All the doctors know you, and they will give you preferential treatment. They also know your class. Even though you're not gone, they can tell your social class. When we go there, we're treated so badly. We're shouted at. We're abused. We'd rather go to the private sector because at least there we're treated with dignity. My friends, this is not just true of the people who work in my home. Poor patients in India's health system are repeatedly, and there's a rich literature the Commission has drawn on, treated neglectfully, humiliated, and when respect is given, it's entirely conditional on their ability to pay, their caste, their religion, or some other form of social identifier. Some of the worst abuses happen in labor rooms. I mean, those stories are so horrendous that I cannot imagine. The only reason why a woman would choose to go to some of those public sector labor rooms is because they don't have a choice. The utter and sheer humiliation and indignity of women's voices in obstetric care, it just reminds you of where ethics, values, and dignities are lost. I'm reminded of another very important piece of work led by Dennis Xavier from St. John's Research Institute in Bangalore, which I often cite to my students as a reflection of how social class influences health outcomes. Dennis Xavier, along with led a consortium of 100 hospitals, both private and public, from around the country. And what they were asking was a very simple question. If you go into a hospital with a heart attack, what is the kind of care you receive, what treatment you receive, and what happens to you in the week or 2 weeks after the heart attack has been completed. And what he then did was the paper was published in the Lancet. It was one of the very important publications to come from India. What they did was they asked a very simple question. Is the quality of care you receive and the health outcome different according to how rich you are? And so they had data from these 100 hospitals that characterized your income, and then they organized people according to income strata. In a nutshell, and this won't come as a surprise to anyone here, if you were poor, you were far less likely to get any form of cardiac treatment. And importantly, this translated into a double mortality rate. So just pause and think about this. It's the same disease, exactly the same disease. So the study was, you only entered into this study if you had exactly the same disease. Medically speaking, there was no difference between any of these people. Yet, one group was twice as likely to die than the other, and the only thing that differentiated these groups was how wealthy you were. Research across settings shows that this lack of dignity and quality is not incidental, but it's embedded in structured hierarchies of caste, class, and gender. And of course, it's further reinforced by poor regulation. Rather than isolated instances, disrespect and humiliation are patterned practices that signal to poor patients or patients from certain castes that they're less worthy of time, less worthy of information, less worthy of comfort and care than wealthier or higher status patients. I want to switch briefly to the second strand of work and then end. In the second strand, remember I mentioned the two different strands I'm going to draw into this lecture. The first is my work on the Lancet Commission. There's so much more I could say about that commission. Just one more thing I will say is that I hope very much that we can work with the government of Goa and convert Goa into the model healthcare state, because if there's one state, being from here and living here for all my professional life, I can say if there's one state in India that could actually achieve person-centered care, it is Goa. The second strand, I will say, is the work of Sangat that I mentioned earlier. Sangat is celebrated today globally as a pioneer organization in demonstrating how we can leverage community resources, for example, one another, lay counselors, community health workers, and so on, to deliver mental health care. And you might ask, why is that important? That's important because such a vast number of people who are struggling with their mental health in India today don't receive care. I'll give you a government's own number. The National Mental Health Survey, which is the world's largest, India's largest estimate of the proportion of people in India living with a mental health condition, commissioned by the Ministry of Health and Family Welfare, reports that roughly 10% of India's adult population, that amounts to about nearly 100 million people, 10% of India's adult population is living with a mental health disorder. That number itself is staggering. But an even more staggering number is the report demonstrating what proportion of this 100 million people actually were able to access care for their mental health condition from any part of the health system, private or public. And it turns out the answer is about 10%. So the even more staggering number than the 100 million is that 90 million of those receive no care at all. And so that's really the kind of care gap that Sangath has been innovating for nearly 3 decades, identifying across a range of human health conditions from autism through to dementia and old age. And one example of that I want to just speak about a little bit to give you a sense of what these interventions look like is the Healthy Activity Program. This is an intervention for severe depression that we developed in Goa. It's a 6-session treatment which can be delivered by any appropriately trained health worker. Definitely does not need a psychiatrist or psychologist, because our whole philosophy has always been empowering ordinary people or non-specialists to deliver healthcare. We ran in Goa the largest randomized controlled trial ever for depression treatment in India, and indeed one of the largest in the world, published our findings in the Lancet. This treatment showed huge effects in terms of recovery. And now that particular treatment has been adapted and is being delivered in countries around the world, from Nepal all the way through to the US and Canada, making this perhaps a rare example of an Indian clinical intervention that has now been exported to the wealthy world. Now, many of you will say that alone is good enough, right? I mean, you've designed a brand new treatment that is being used around the world, including, of course, in many parts of India. What has this got to do with dignity, values, and ethics? We've always been interested in Sangath to go beyond the clinical outcome, to actually ask our trial research participants, what did you find was really beneficial about the care that you received? And we have published now many, many studies which are qualitative and ethnographic in their very nature, asking people what they experienced. And in a summary, what our participants routinely and regularly tell us is that it wasn't the clinical benefit that they really valued. What they really valued was the engagement with which the providers addressed their needs. Here are some words they used. They are accessible. They're respectful of my identity. They're personally meaningful. And they often would contrast this with the fragmented, impersonal, often elitist care that they received from the formal medical system. Our trial participants emphasized relational qualities like what? Empathy. Empathy is a very powerful word in the healthcare system. It's a very simple premise, to feel the pain of others. Empathy is a deeply important skill that Sangath has always championed, alongside being non-judgmental, having a listening capability. And of course, many of our patients would tell us, that lady that was visiting me, she spoke my dialect of Konkani. She dressed just like me. She looked like me. I felt comfortable with her. These were central to their positive experiences. These skills meant that a subject as taboo as depression, which is of course a mental health problem, and it's not just taboo because it's a mental health problem, but also because for many of us, the depression we experience is linked to very private experiences in our lives, marital disputes, alcoholism in the home, etc. These are very personal, private kinds of issues that are also imbued with shame. In spite of that, our patients freely could speak to our counselors about their mental health. Indeed, these are such critical soft skills that we refer to them as foundational skills. They are competencies. You know, when we train our doctors today, we only train them on competencies of how to diagnose and treat a fever, for example. I believe that these foundational skills are central competencies for any healthcare worker to provide care with dignity and that respects the values of our patients. So I want to end by just giving you some summary about some of the key things that I think we could be doing together as a society to embrace this knowledge and make our healthcare system champion these important attributes that this conference is speaking to. First of all, we need to move our healthcare system from being doctor-centric. Right now, we design our healthcare system around hospitals, clinics, doctors, and one that therefore only responds in a reactive way. Somebody comes to you with a pain somewhere, we react to that. And our delivery system is very fragmented. I fear the day that sometimes it's going to get so specialized that if I have if I have a problem with my left thumb, I'll have to go to a left thumb doctor, or right thumb, a right thumb doctor. We have lost the person completely from our health. You know, the more I see these hospitals, they say, now, you know, there was a time when you say specialty hospital, then that became commonplace. It became super specialty hospital. Now it's super specialty hospital. When is this nonsense going to stop? It's time to put the person at the heart of our healthcare system, not the specialist. We need to transition from focusing from merely physical access to healthcare services to ensuring quality in every aspect of what healthcare we provide. That means treating every person, regardless of their station in life, with dignity and respect. To do that, we need to transition away from a focus on degrees. Our country is going to do that. I know it is. It's already happening. And as a principal of a college, you can see that change happening. People are no longer asking, do you have a BA or an MBBS? They're asking, what are you competent to do? Do you have the necessary skills that our society needs? A skill-based educational system is what we need to move towards. And again, repeating, those skills are not only are you rightly diagnosing or prescribing, but are you also showing the necessary foundational skills that are needed to provide the right quality of healthcare? I know this is going to be controversial, but I know that right now in our healthcare system, there's a big contest going on between the biomedical allopathic system that I come from and the Ayush system that our chief minister comes from. And you know, I've thought a lot about this, and during the years as the leader of the commission, it got me to think about the Ayush system a lot more. I don't use Ayush myself because I'm a firm believer in the allopathic system, but I believe people should have a choice. You know, I'm a firm believer in the principle of choice, and we come from a very plural and diverse country. And I've begun to believe much more that if Ayush doctors can display the same competencies as allopathic doctors, it doesn't matter what their primary degree is, because anyway, 80% of what they learn is the same as what an MBBS doctor learns. And so, if we adopt a competency-based approach rather than a degree-based approach, we would be able to automatically expand our choices for healthcare. We need to go beyond just training our doctors and nurses to continued supervision. I can tell you, no doctor in the public system and the private system is supervised. Once you finish your MBBS or your MD, it's like that knowledge will last you a lifetime. This is not the way healthcare is practiced in most other parts of the world. You have to every year submit documents demonstrating your competence, and typically that is done with your peers. We need to move into a system of peer supervision of doctors and nurses and quality assurance. In Britain today, for example, you can go online and you can check for every hospital what health outcomes are. And it's because of that that the British system, I remember very well this happened. There was a hospital out in one part of Britain where if you went in with a heart attack, your mortality rates were 3 times that of the national average. This is important information. It means something is happening in that hospital that needs a further inquiry, at least an inquiry. And you as a consumer, just in the same way that you can go online and check, does the Creta have a longer mileage than some other car? You have the right, we have the right for such kind of information to guide our healthcare choices. And so my final point is a transition from citizens being passive recipients of healthcare to becoming active agents, both with rights but also responsibilities. And one example of that is we borrow on many other countries is citizen information. I hope very much that in Goa, for example, I was speaking to the health minister recently, we're moving very quickly in Goa towards a fully digital infrastructure with Aadhaar IDs and so on, that one day I will have access. They're going to build a transport app that can tell you when the next Kadamba bus is coming. Why can't we have an app that tells me which clinic is open in my immediate neighborhood, how far is it, and I have chest pain, which clinic is ready to receive me in order to do a proper cardiac check. So information about where I get care, what kind of care will I get, what are the medicines that I should be receiving. This should be standard information that each and every one of us gets. And then, of course, the holy grail is information about the quality of the care that I'm getting at different hospitals. So let me just finish by just saying this, friends. I believe this conference is touching on an extremely important theme. In my view, if we are going to actually achieve universal health coverage, we can only do this if we fully embrace 2 core principles and values that I believe are central. And that is the value of rights, that each of us has a right to healthcare. We don't have a right to an air conditioner. We don't have a right to air travel, but we have a right to healthcare. It's a fundamental right, and in fact, it's a right that is written in our Constitution, so we don't even have to make up that right. It exists. And the second is to value equity, justice as a core value, that regardless of our station in life, we must receive the same quality of healthcare. These are very, very fundamental foundations of a system that is committed to compassion, dignity, ethics, and values. An overarching principle in the Lancet Commission is that the people of India enjoy a universal, fundamental, inalienable right to health, and the government must be accountable, not only for financing and operating the public system, but also for stewarding both the public and the private systems. To realize the vision of Viksit Bharat, India must therefore invest in a health system, innovate boldly, and keep every reform responsive to her citizens' right to health. I firmly believe the wealth of our country is not in our GDP, it's not in the assets of our corporations and our shareholders, but is deeply vested in the health of each and every one of us. With strong political commitment, which we currently do have, with strong innovative technologies, which I am very bullish about. I am amazed, for example, not just at CoWIN and so on, but the UPI platform. Think about UPI. I always tell my students in the West, in the US, which country has built a financial services platform where there is no middleman? Only India has. If we can build a system with private technology backing it, because the system was built in Bangalore, these are some of the world's wealthiest companies, taking not a cent of taxpayer money. Today, the credit card companies must be wondering what is going to happen to them because we've cut the credit card companies out. To me, this is what India is capable of doing. With the right combination of vision, ethics, and values, if we can build UPI, we can build exactly the kind of healthcare system I'm talking about, powered by technology, and of course, active engagement of people across our diverse country. India can ensure that our future prosperity is anchored in a health system that is resilient, inclusive, and truly citizen-centered. Thank you very much.
Thank you, sir, for your very insightful address. To briefly sum up what Sir mentioned in his address, Sir began with the introduction of Lancet Healthcare Commission and introduced it to the general public. Sir spoke about the app with which COVID vaccination could run about seamlessly and how the app has evolved into the backbone of India's evolutionary take on healthcare, which is Ayushman Bharat app. Delving a little into the historical aspect of healthcare, Sir spoke about two important commissions, that is the Boer Commission report in India and the Beveridge Commission in British, both of which were established at the same time. However, the sad reality lies in the fact that Boer was never really implemented in India, whereas Beveridge Commission in the British soared and raised well. Sir spoke about the Indian healthcare system, where access is no longer the problem, as access has been reduced to a narrow focus, focusing only on the vertical programs, disease-centric and doctor-centric. Sir spoke about the transformation which occurred in the 2000 under the Prime Ministership of Manmohan Singh, where an universal approach was embraced, and the civil society was considered as a part of the healthcare, where the civil society was actively involved in it as well. So spoke about some of the work that they have conducted, where on his commission, which consists of diverse representations within his committee, they developed a set of research problems, conducted a citizen survey of 50,000 randomly selected households, and traced their experiences and preferences in terms of healthcare. They've also collaborated with IIM Bangalore, and through their research, they've tried to identify what are the rights of the citizen and how healthcare has been offered to these people. Sir spoke about the quality of healthcare, how it affects every aspect of the state. Sir gave a very interesting metaphor, an analogy of schooling, how back in the day when schools were not available, the colonizers, that is the British, they came up with several schools, did not really look into the kind of quality that was offered at these schools, just ensured that several schools were built. Similarly was the stance of healthcare in India as well. Quoting some of his work at the Lancet Commission, Sir mentioned in 2018, 2 million Indians died due to poor quality that they received in healthcare, which was sadly twice the same number of people that died for not getting access to healthcare. Sir's address drew on two thematic tracks, where Sir spoke about the theme of ethics, the identifying the competence of doctors' contribution, and how low competence could be seen through irrational prescription of medicine and diagnosis, causing individuals to in turn be resistant to the medicine which was prescribed irrationally. Finally, Sir believes that healthcare is not an industry, as there is no choice offered to the kind of healthcare which is meted out to the people. Sir upholds the idea, the notion to be ethical, and through their work with Sangat, Sir also aims to incorporate such a model in Goa as well. Drawing on the second thematic track with which Sir spoke, he identified the kind of work that Sangat as an NGO has put into perspective. He spoke about the several interventions that Sangat has taken up, identifying programs to cater to severe depression cases, spanned over 6 sessions, which can be implemented by any trained professional, and of course, which has had a huge effect on the healthcare system. Finally, Sir concluded with the things that we can do as citizens, where we can move the healthcare system from a more doctor-centric to a person-centric approach, ensuring quality and embodying dignity irrespective of the social standing of the patient. people should have a choice, and competency-based approach should be shifted from degree-based approach, we should shift to competency-based approach of the medical professionals. And finally, Sir ended his keynote address with identifying the role of the citizens, how the citizens should not just be passive recipients of care, but also have an active involvement in understanding their rights and be knowledgeable about the kind of healthcare systems and healthcare facilities that they receive. Thank you so much for your address, sir. With these thoughtful words setting the tone, we are confident that the deliberations ahead will be animated with the same spirit of inquiry championed fervently by this conference. At this juncture, I request our trustee, Madam Pallavi Dempo, to present our keynote speaker, Professor Vikram Patel, a token of our appreciation. If any of you have any questions for Professor Patel, you may kindly raise your hands. Sir would be delighted to answer your questions.
Good morning, sir.
Good morning.
I'm Dr. Maheshwari from KLE Medical College, Hubli. I would like, as you spoke in your talk regarding AI, so would you like to opinion about AI in health sector and how empathy and psychology will be dealt with that?
So that's a great question. It's a rapidly evolving field. So much I can say about AI because in my medical school, we are completely overwhelmed with the possibilities, but also the challenges. But the question you're asking is really important, which is to what extent can AI provide empathy? And, honestly, it depends on who you speak to. Some people would say that AI can never show empathy because it's not human. And only humans have the ability to show empathy. On the other hand, other people say that unfortunately so many humans in the healthcare encounter don't show empathy, that actually AI may come across as being actually more empathic than your regular doctor. So my sense is that in our medical training at Harvard now, we are putting a lot of emphasis. So my department that I chair is specifically concerned with teaching our medical students what we call essentials of the profession. And those essentials are entirely built around the issues that which I spoke about in my talk. That I do not think AI can ever replace. AI will replace, I will tell you, and it's already happening at one of our big hospitals called the Mass Gen Hospital. Very scary data, which will answer your question and make many of my medical colleagues a little nervous. They did a study which has now been published in which they presented clinical case vignettes to Mass Gen is one of America's greatest medical school hospitals, and to AI, an AI engine. This was last year before they even became better as they are now. And the AI engine was actually of the same level of competence as America's best doctors. This was last year. By this year, they probably are outdoing America's best doctors in terms of technical skills. That's what I want to specify, getting the right diagnosis and making the right prescription. Personally, I am pretty sure that hospital corporations are looking at this very closely. And that even though right now no hospital is going to replace the doctor, take it from me, within another couple of years, I can predict that entire groups of doctors are going to vanish, like radiologists. And so I think as a medical profession, we need to ask very important questions about the role of the physician. The one profession that I'm sure is looking at this with a lot of glee is the nursing profession, because the nursing profession can never, ever be replaced by AI. Think of it like this, and this applies to all our things, the thoughts about work, is anything that involves interpersonal care, contact, or working with your hands, those are the least affected. Anything that involves working with your head, unfortunately, the thing that we championed so long, those are the things that are most threatened by AI. And that's how in our curriculum, we're re-examining which medical professions may even cease to exist or be attractive 5 years from now.
Thank you, sir.
Hello, sir. I'm Kushinara. I'm doing my MSc in clinical psychology from Christ. Firstly, great topic. I mean, the way you had an intersectionality perspective was really, really intriguing, because you also mentioned the gaps in healthcare. And you mentioned about equity and accessibility, and that was really great. And because you also said that you like implementing it in Goa would be more, feasible, or like you see the vision, and that completely makes sense. So where do you think we can start from? Because you did mention the gaps, but like systemically or anything, where do you think we can start from?
So I think we do very well in Goa on all acute care. We do extremely well. If you had an accident or you had an acute cardiac event, I think we're pretty good. Where we fail is chronic care. And unfortunately, those are the diseases that are going to kill most of us. Most of us are not going to die of a car accident. We're going to die of diabetes. We're going to die of, uncontrolled hypertension, etc., high blood pressure. These are lifelong conditions. They're chronic conditions. And a system like ours, which is very episodic, it's reactive. It only gets involved with you when you have a problem, rather than gets involved with you to keep you well. You see, the outcome is completely different, right? Your frame of reference is different. If I say my healthcare system is designed to keep me well, the way I would design my healthcare system would look completely different to the one that we currently have, which is how do I treat you when you're sick? They look like similar endpoints, but they're not the same endpoint at all, in fact. So a positive health framing would mean that if I have diabetes, the system accompanies me right through my journey to ensure that my blood sugar always remains beneath a certain threshold, which means I have a coordinated health system from a community-based health worker or sub-center in Goa all the way through to the diabetic expert, providing me coordinated care. This may sound a little abstract, but it's not. Actually, it's a fairly well thought through system in the West. Many places already have that. Now in Goa, we already have everything in place. What we miss is coordination. And this is where technology can be very, very helpful. Imagine a system in which a diabetologist sitting at Goa Medical College says, you've got very high diabetes. Where do you live? Well, you live in Bicholim. Okay, fine. This is the health worker who will visit you every week, or you need to go visit to do your blood sugar monitoring, who will give you dietary advice, etc. You only have to come every 3 months, but in the middle, all your blood sugar measurements will be uploaded onto my app. And so if I see something odd, I can immediately communicate with that health worker and say, no, just check their metformin. This sounds like rocket science. It's very simple given what we've already built. And it's more about coordination, and technology, I believe, is going to make that a much easier task now. So when I was speaking to the health minister, I said, pick 2 or 3 conditions like this. Like diabetes is obviously a no-brainer, because it's so common. But also in my own field in Sangat, we said take autism. It's a rare condition, but one that is, again, a lifelong condition, requires many different components of care, not just the health system, but education system as well. See if we can take 2 or 3 what we call tracer health conditions and build this coordinated universal healthcare system. And through that, we gradually expand and create a comprehensive universal healthcare system.
Thank you, sir.
Thank you so much for your wonderful talk, Dr. Patel. You covered all aspects of ethical medical care, and that was wonderful to listen to. I was wondering, as a doctor working in rural India and having done that for a long time, I was wondering whether, and having seen all the, the difficulties that we have in medical care, including it becoming an industry, and the way the less advantaged people are treated in hospitals, and the inequalities, the unethical way pharmaceuticals work, all of this. I was wondering whether, because we have to keep training doctors, and we are going to have more doctors of whatever, whatever way it evolves, because of the AI that is coming in. But I was wondering whether it would be of value now to consider, since you are trying to work on a big mission, about having humanities as a subject for medical students, which becomes a part of the medical curriculum. Right now, a lot of medical colleges do have humanities as a sort of an elective. We are trying to do it at St. John's, and so that helps, of course. But if it was to be done in a better, more organized way, that humanities is absolutely vital to make the doctor understand the meaning of empathy and how it is used as a doctor, and also to tie up with all the ethical values. So if humanities could be brought in, it would be a great idea, I feel, and it's just a suggestion. And also, by the way, I was happy you mentioned Dr. Dennis Xavier's work, because he's a junior colleague of mine from St. John's. Yeah, so thank you.
No, so I completely agree with you. I mean, I only became aware of the importance of humanities after I left medical school, which gives you a sense. I trained in KEM Hospital in Bombay, in the late 80s, and there was no mention of it. Did not exist. This word humanities, in fact, did not exist in my vocabulary till I sort of started, doing my further education in Britain. But where I've really discovered humanities is in my current role as a chair of a department that does very foundational teaching of medical students. Because my department, medical humanities, is anchored in my department. So my faculty are fascinating, and it's such a great example of what medical schools can aspire to. Of course, I have the traditional medical specialists, surgeons, gynecologists, and so on. But half my faculty are historians, anthropologists, and come from the social sciences. And so I think that you're absolutely right, that to prepare out even more urgently today to follow on to the AI question, our focus has been so much on the technical cognitive skills of medicine, which are quite sophisticated, but we're suddenly facing a reality where those are going to be outclassed. There's no question they're going to be outclassed. I have zero doubt in my mind that those technical cognitive skills that we have focused so much on medical education for the last 50 years, it's going to be replaced by AI. What is left? It is the humanities. It is the humanity with which we engage with a patient. It is the one thing that actually will demarcate us from a machine. And I think, as the old style doctors would say, I'm sure many of you, well, I guess many of you are not physicians, but we used to say the art of healing. The art of healing has shifted from it shifted from, the interpersonal to the technical. And maybe now is that historical moment when the interpersonal will again be foregrounded, if only because it's a matter of our survival as a profession.
Thank you. Hello, sir. I would like to know the interventions on curing depression that you mentioned. Like, can I find it? Where can I find it, and how can I implement it? Because I'm a master's in child psychology, so it will be of a better.
Come and meet me at the lunch break.
Yeah, perfect.
But basically, you can find it very easily on the Sangat website. And you can also find it on my Harvard Medical School website, because actually the same intervention has now been adapted and it's being delivered in the US and Canada. So, but it's easy. The training is entirely video-based online. That's also something that Sangat has developed. Also, Harvard has developed it. But obviously, you can't just watch a video and become something. It's the first bit. Then you have to do case-based practice. And then you have to do an exam, which is competency-based. So again, it focuses on the whole shift in medical education has shifted to competencies now, and including in India. And so, the aim is to make doctors competent rather than just having textbook knowledge, which is what I was trained in, by the way. Those of us from my generation, we used to get big fat textbooks, and the whole aim of medical education was to memorize the 10 top causes of this and the 10 top causes of that. Today, any phone will tell you that. That is not what you should be armed with your knowledge. It's what are your competencies in terms of asking the right questions, etc., that are now being much more valued.
Good afternoon, sir. I'm Lubna from Stella Maris College, Chennai. First of all, beautiful keynote address. I would like to say that, yes. And with regards to my question, you spoke about some very crucial ideas on the quality of healthcare, reducing and experiences and competence of doctors not being adept. However, I would also like to speak about how doctors, therapists, and psychologists are also overworked, underpaid, and treated inhuman, and more so like a robot. So how can we address the quality of these professionals being incompetent when this is the floor of treatment, resource, and humanizing experience that they face?
Yeah, no, you hit on a very important, it's actually a demotivator for healthcare workers to behave in a manner that's ethical. Because the moment you have ethics, dignities, and values incorporated in your healthcare work, it requires time. And the pressure that you're under to, generate more patient revenue, etc., is at conflict with that. That's in the private sector. In the public sector, there is a different kind of problem, which is that, one day, you are sitting in a clinic, but the next day you're transferred somewhere else. You have no sense of security. Your life is being controlled by forces that are outside your control. So you're basically disempowered. You're disempowered in both areas. And so absolutely in the commission, we do speak about motivation as a very important asset of every healthcare provider, like it is for all of us. If you're not motivated in any way by incentives, for example, that will reward you for good work, then you'd rather basically not do anything more than what your job is asking you to do. And I see that a lot in the healthcare system here. I've seen this, by the way, in Goa a lot. And it's a problem when you disempower healthcare workers. And I think it has to be addressed. It has to be addressed. There are many prescriptions for this, by the way, which I'm not going to take time in. But again, offline, I'm happy to share this with you. Plus, by the way, the Lancet Commission is completely open access. So if you just type in the Lancet Commission for a citizen-centered health system in India, you'll be able to access the report, all the commentaries, everything is available open access. Okay, thank you so much. Thank you.
Sir, sorry, there's one last question. Sir, I'm Marina Martins. I teach at Don Bosco College. The higher education system in Goa is mostly not inclusive of neurodivergent students. They are forced to adapt to a curriculum that was constructed for neurotypical learners. Because of this, most of our students who are neurodivergent end up being neglected, or they just drop out, they do not graduate. What can we do to address this problem?
Wow, that is a big question. Most of my work with my awareness and Sangat's work has worked very centrally has been with schools. But I have never actually had this question about colleges, and that's a really important question. I don't have experience to answer that question. But I think clearly what you're speaking to, one way that I can imagine you could contribute to this, the answer to your own question, is to document individual stories. There is, this is not about numbers. This is going to be about individuals that are willing to share their stories about how, being neurodivergent, how that was experienced in a college environment, and actually then sharing those stories with relevant decision makers. I don't think people even think that neurodivergent individuals land up in college. My sense is this is a kind of patronizing thing. I'll give you an example. There was a time when people said, oh, that child, why do you want to bother him with him going to school? You know, he's neurodivergent. Keep him at home only, no? Now that is not accepted, right? But I think what we may have done is just push that age band. Said, okay, now the child has gone to school. No, now what college? Oh, what is the point of sending him to what will he do in life? You know, I mean, a lot of us carry those attitudes. No, even if you send him to college, he's anyway always going to sit at home only. So I do think it's about changing public attitudes about these very specific groups of people in our society. And it's about pushing the envelope through storytelling. I think storytelling is a very powerful tool here rather than the more traditional biomedical research.
And that was the last question.
Thank you, sir. This conference stands at the meaningful intersection of healthcare and humanities, bringing together diverse perspectives to explore empathy, ethics, narratives of healing, and human dimensions of medicine. We will now begin with the plenary sessions. Our plenary speakers aim to spell forth this amalgamation through their sessions. Our first plenary speaker, Dr. Shivashankar KN, is an eminent professor of medicine at Kasturba Medical College, Manipal. An alumnus of the same institution, he earned his MBBS in 1993 and his MD in 1996, subsequently dedicating over 3 decades to clinical practice, medical education, and specialized research. He is a live member of the Indian Medical Association, IMA, National, State, and Local API member, National Hypertension Society, RSSDI, the Indian Podiatry Association, Indian Diabetic Food Society, and local IMA. Fellow of ICP, Indian Association of Clinical Medicine, International Medical Sciences Academy, and Royal College of Physicians and Surgeons of Gascon. He is also a member of the American College of Physicians and has been the immediate past president of API Udupi Manipal, Chapter 2024 and 2025. A recognized leader in organized medicine, Dr. Shivashankar served as the immediate past president of the API Udupi Manipal, Chapter 2024-25. Under his chairmanship, the chapter achieved significant distinction, receiving the Best District Chapter Award at both the state level, Capicon 2025 Hubli, and the national level, Apicon 2026 Patna. Dr. Shivashankar has made substantial contributions to medicine, literature, and clinical research, with over 69 peer-reviewed articles indexed in major scientific databases. He also serves as the reviewer of the International Journal of Diabetes in Developing Countries and the APIK Journal of Internal Medicine. He has also led 3 IMCR-funded projects and has guided 8 doctoral candidates fostering the next generation of clinical research. I request Assistant Professor Dr. Svetlana Fernandez to present a bouquet to welcome our first plenary speaker, Dr. Shivashankar.
Thank you. Thank you. Thank you.
The title of the plenary address is Upholding Dignity in Patient-Practitioner Relationships. I would like to invite Dr. Shivashankar to kindly address the gathering.
Thank you for a nice introduction. I think first of all, I would like to thank our team of this, that is multiple, divergent, disciplinary, it is a psychology, literacy, artist, and medical perspective, with the theme of ethics, values, and human dignity in healthcare. Wonderful audience. After hearing, I think Vikram Patil sir, my job is very easy. I think he has spoke on evolution of health system in India and what is his vision regarding health system of India, what we are going to have next future, next probably 100 years. So I am going to talk on the most important topic, upholding of dignities of doctor-patient's relationship. I think somebody already asked about some query regarding what exactly going to happen when the person is we are with the technology-based era. So this technology-based era, we are with this, it has a lot of impact on medical field, especially AI, telemedicines. First slide, please. telemedicines, and wearable devices, 3D printing. Just go back to the first slide. You're going to, yeah, just go back. Yes. 3D printings. So all these are different softwares are coming to the medical field. It's okay, fine, thank you. So when these things are coming up, how much contribution we can get it for personal diagnosis, treatment of any patients. Personally, what we can do it, what we can offer. I can give you, start this topic with one examples. Nowadays, everybody is busy with our activities, our job. 40 years man, his colleague, 45 years in office, died suddenly. And next day, he goes to the internet and starts seeing I had to undergo some investigations. So he goes and start doing searching for some website or some lab where I can have investigations. So he goes, sees, because in India especially what I can see is people are looking at which is the cheapest lab we can get it, more investigations. So he goes there, he gets the investigation from one company, he goes, draws a blood, he comes home and he draws a blood and sends a report online to his office. He was very happy. After seeing this, he says, he look at that some ranges. By looking at the ranges, his blood reports some are orange color, red color. He's worried. Then he has to consult some doctor. Then he started thinking about telemedicine because he's a professional man. He's uploading this to some telemedicine and this telemedicine person gives some interpretation of this report and finally he gives some answer. And he says, for these reports, I think you personally consult a doctor. Then he gets a consultations appointment with a corporate hospital. He goes there. When he goes there, then probably he gets a history of this person. Then the examination. Then he said, all the values are normal, but they had done, he's a male gender, they had done estrogen level, progesterone level in the package. Actually, this is supposed to be done for a female. But he's worried for this. There is no reason, because he wanted to do cheapest blood test, more blood test, and this to be interpreted by one company. That is telemedicine. There is humanity is not there. There is dignity is not there. Then finally he went to corporate hospital. Then he said, this corporate doctor said, yes, you have some amount of fatty liver, mild borderline overweight is there, and you have to diet and exercise. Then he said, this diet and exercise I can do it, so I can go ahead with this. Then he said, no, this should be done. You just go and meet our dietitian and nutritionist, so they will help you to get a good diet and exercise. He said, I can do these things. He left. After 5 years of this real story, he had acute myocardial infarction, admitted in the same corporate hospital. He got it treated with the same patient, same doctor. Imagine this is a situation of happening in India. People bypassing doctors, getting treatment online, not satisfied, correct advice they are not going to take it, and they blame on doctors. Is it true? Every day is true. Thing is, as sir was saying, non-communicable disease taking upper hand nowadays. We ignoring it because it needs something, we need attention for this. So this is what very, very important. The link is between the public and doctors are very, very important. It is mandatory. How we had a COVID vaccination mandatory, similarly, probably government has to do a mandatory evaluation for this non-communicable disease so that our life expectancy may improve. People probably have a good life expectancy, good, better care of life. Yes, I am going to start this. This is from, it's not going down. Yeah, greeting from Udupi Lord Krishna, blessing from Lord Krishna, and greeting from our University, Manipal Academy of Higher Education. It's an education hub. Next slide, please. So this is my outline of my talk. First, I am going to talk in definition, introduction, doctor-patient relationship model, core principles of dignity of patient care, expectation of patients and doctors, strategies to uphold the dignities, and consequence of dignified care. Finally, the summary. Next slide, please. So, what is dignity? Dignity of care is a practice of treating individual with, please go back to the previous slide, respect, compassion and equality, supporting the self-respect, independence and personal choice. It is nothing but it is essential tool for standard practice. It is essential tool for a standard practice. It is not given to someone simply. It is the response of the person. Next slide, please. So, doctor's relationship is a central part of healthcare and practice in medicine. In ancient Egypt, doctor is known to be a magician or priest, because they think that he is a magic, he is doing a wonder, or he is a priest, so he is going to cure the disease. Similarly, Hippocrates oath in ancient Greek ethical code of family physician, he is focusing patient safety. That is in 460 or 317 BC, he has said patient safety, confidentiality and professional conduct. This is very, very important. Three terminology he has told that time. But look at here, he pledged first do no harm, treat patient to the best of his one's ability, respect teacher, main strict moral standards and including privacy. The last sentence is the doctor-patient relationship is changing drastically over the last course of history. That is partly because of we are getting more and more knowledge, access to the multiple information medias, and probably our economy is getting better, and we have a negative image on doctors. People may think that PhD doctor is making money. It is not so, not everywhere. Next slide, please. So, initially we think doctor is not a profession. It is a responsibility, great responsibility of saving life, a noble value that provides priceless service. Money can get anything, but only doctor can save the life. Doctors are not just people with white coat with stethoscope around the neck. Doctor is a passion. Doctor is relations, responsibility, doctor last hope of life and respect. This is what we thought probably about 100 years back, but slowly it's changing. But if you look at it at present, preparing or making a good doctor is very, very difficult nowadays, because bad society is not going to produce a good doctor. Please understand this, when the society is bad, it is not going to produce a good doctor, because everywhere is a corruption, everywhere is a different variety of people are there. It's difficult to produce a good doctor. The easiest way to sue or any profession is doctor's profession. Any profession you take in the world, easiest way is you can sue a doctor. Anything. You can go and ask and some question and ask sue them. This is very, very simple. That's why nobody wants to become a doctor nowadays. Next slide, please. So this is what changing era of doctor's life. The mother is or teacher is asking, write a note on doctor. The son says, I have to study 10 to 15 years of doctrine laws, no family life, harassment by politicians, attack by patients. So all these things are happening. So do anybody wants to become a doctor? No, because the problems are more. So nobody wants to become a doctor. Next slide, please. So this is the other part of the story. The patients in the middle income countries, they are getting violence. You can see there's all happen, fake certificates, negligence, all things are happening. That is because of several factors. One is overworking. Workloads are more, doctors' workloads, harassment, and communication skill is very, very important for doctors. Have a good communication skill with the patients, that 50% job is gone. It's improved because the communication is the art of clinical practice. If they have a good communication, the 50% of the work is done. So they can communicate the people, because literacy is the one, probably they can go to that level of illiterate person, they can teach them so they can understand the illness. So most important, the overcrowding and time work. People do not have a lot of time to do this, and probably they have communication skill. These are the important factor why patients are getting untrust or negative image on doctors. Next slide, please. So this is what you can see. Here the signal is there. People having accidents, two vehicles having accidents, they have damages, but we don't know. Everybody, he thinks, both of them thinks they are correct. Both of them think that they are wrong. Both are injured. So same way doctors and patients. So both are having problems. So only thing, if they follow ethics, probably it will become better. Next slide, please. So if this is what a recent data from IMA, over 80% doctors in India are stressed of their profession. They say, who will take the doctor's profession now? I don't think nobody will take. 80% doctors feel stress in their entire profession. 46% has a fear of violence in main cause of stress in many doctors. 24% doctors are fear of suit. 62% doctors are surveyed unable to see their patient without any fear of violence. That's why they'll hire the securities. See here, 56% doctors are not getting comfortable sleep, minimum 7 hours. And 13.7% of fear of criminal prosecution most of the day of week. This is what is going to happen. This is a real scenario, what is shown by IMA. Next slide, please. Next slide. That means being a good doctor is not easy. So if you want to become a good doctor in this atmosphere, is it possible? Yes, possible. That's because several reasons are there. You have to overcome this. High stress and emotional tool. This is what one of the important things has to come out from this barrier. Intense workload and competitions. These competitions, especially in private sector, this is mainly in the workload in the government sector. Physical and mental health, I told you, most of the people are 80% are stressed out. Constant learning, as I was saying, it's India, we don't have updating our knowledge. This is what initially, I think about 10 years back, they started with every doctor has to undergo CMEs and they should upgrade the credit to IMA and probably their councils. It's not happening nowadays, but it's very important to updating their knowledge. High stake of decision making, especially nowadays coming with multiple comorbidity diseases, making a diagnosis very, very difficult, it's time consuming. But patients are getting restless with this. And lastly, too little reimbursement. Whatever they take, this much, so much risk in their life, the outcome, the money they are getting, it's very, very poor. I'm talking about a common practitioner. I'm not talking about a corporate persons. I'm talking about a common doctor who is serving public. Next slide, please. So what is the quality of good doctor? Active listening, empathy. What do you mean by active listening, empathy? When the patient comes to a doctor's chamber, at least he should listen to the patient carefully. At the same time, he should have eye-to-eye contact, sitting near the end of the patient. So he should listen carefully, acknowledge their feelings and sufferings. It's very, very important to look at empathy. Next is clear communication. Just go back to the next slide. So next slide. Yeah, you can see here non-verbal, how much is the importance, and verbal communications. Smile is the one is going to give respect to the patient. Very, very important. First smile while entering the chamber. Next is open posture. It is nothing but when sitting, we should not cross the hand, should not cross the leg. This is what is important. It is not a good respect to the patient. Sit, lean forward, listen to the patient's story. It's very, very important. It is you are giving a respect to the patient. Forward leaning and touch is very, very important. When it really essential, you should touch the patient. Next is eye contact, very important, because nowadays every person, every second, anything is free, they will open the mobile, open the laptop, desktop. So this is when you are taking the history, you are taking doing the texting, looking at email, it is not correct. You should have eye-to-eye contact with the patient. It's very important, you respect to the patient. And last is, at least should nod the head when you are listening the story or history. It's very, very important, because we should not interrupt the person. Verbal communication, only 7% spoken words. And 38% voice quality, tone, tempo or intonation. And 58% body language has a lot of respect, because your body language is going to give a good confidence with the patient. Just go back to previous slide. So this is what importance of clear communication. It is the art of clinical practice. It judges successful doctor from non-successful doctor. Next is clinical competence and diligence. This is nothing but updating the knowledge of a person. Every diabetics, he should update the guidelines. The doctor should update the guidelines of diabetes, update the guidelines of hypertension, because they are common diseases. Patient will be knowing more than doctors. So they should come with updating their knowledge. Diligence is this very important, updating the patient data. When the patient comes, should go through his data, go through his investigations, go through his past admission or past documents. This is very important to get a trust of patient. Next is respectable and passionate. It is nothing but, in addition to making a diagnosis, for a patient, it's important. For you doctor, it's maybe only treatment, diagnosis. But patient, trust is very, very important, and empathy is very important. These are two things, it improves outcome. Next is shared decision making. It was not there in the past, but now important to know shared decision. When the diagnosis is made for a patient, probably you should have a discussion with pros and cons of diagnosis, pros and cons of treatment, a complication with patient or family members, if they're able to understand. It is a shared decision, makes the patient's outcome is much better. Last one is professionalism and reality. High ethical practice, high standard of knowledge makes the person competent person, and probably it makes him good doctor. Next we should see who is a good patient. Next slide. Open, honest communication. That means when the person comes to you, doctor, he will give a history. Many times we have seen, they'll give you history, and after making a diagnosis with lab test, they'll say, yes, I came for second opinion. But at that same time, if you have told initially, it's very important to tell, sir, I have come for a second opinion. Sir, I have some hidden diseases. It's very important to know. But they should clearly communicate with the doctor. It's very important. Active participation, that is very important, is to active participation in the decision making about the diagnosis and treatment. It will help you to trust and improve the shared decision. Adherent to the treatment plan. Doctor will tell you, yes, you should adhere to the treatment plan, like lifestyle modifications. Treatment should be taken, this medicine should be taken before food, after food, or night. Some instruction will be given, but if he follows it, probably the cure rate will be much better. Respect and trust with the doctor. Last one is preparation organization. Suppose the doctor tells you the follow-up is come the particular day. Nowadays, corporate hospital, they will call and tell you your appointment tomorrow. But a common man, probably doctor will tell you come after 1 month. So if there is a follow-up date is come, probably you should go that time. Because doctor has something in mind. Probably needs to follow up some blood sugar values, or blood pressure medications, or some cardiac medications, or something he must have told that to be done and to go to the doctor. That's very, very important. All these are the good quality of patients. Next slide, please. So if you look at the doctor's-patient relationship, in the history, there are 4 types of models are there. First one is paternalistic model. It's old model. Here doctors is a god. Second one is informative model, deliberate model, and last one is interpretive model. Just we'll go back to the first one. Next slide, please. So this is paternalistic model. Next slide. So here the doctor should make a decision about the patient. That means patient will give a history, doctor will make a diagnosis, he'll take care about everything. So he gives all the confidence on doctor. So this is patient has to give a history, this doctor has patient the best interest in mind, he'll treat the patient. Here relationship is father and child. This kind of relationship they'll have it. Next is people not always rational and mature, and patient allow the doctor to take a decide what is best. And a qualified doctor have a good will, and doctor profession is supposed to be the secret profession and high social status, and doctor follow the Hippocratic oath. That's why probably they think that he is doing a good thing for me, and probably correct treatment he is giving. So this is what commonly it used to happen in the past. Next slide. Next one is informative model. So we are moved to the informative model. Here the doctor is expert. That means he is nothing but he gives you opinion for the disease. For example, diabetes, or he comes to the hypertension treatment. He gives you opinion for that. The doctor will give opinion, but patient or family member has to take a decision about it. So it provides information about the treatment, makes a decision based on the fact provided by the doctor, and increase patient autonomy, decrease beneficence. Patient may not take a decision best of interest. Sometimes he may take a decision, probably he is leaving the doctor or leaving the decision, probably going to the other person, he may harm himself. Because here doctor is giving only options. And last one is, it is opposite to paternalistic model. Next slide. Next one is deliberative model. Next slide. So discuss and understand the value, and this is doctor is a friend or teacher, and educate them best of course, all the decision in the best of interest of patient. Here it is my opinion. He's going to tell you, doctor, it's my opinion, this is the best treatment. My opinion, this is the best treatment. So he is going to give you suggestions. Only he is going, not options. Here he is going to give you suggestions. Next slide. Last one is interruptive model. Here model highlights autonomy of a patient. Patient has a lot of freedom, and doctors will discuss line of management, clarify patient's values, explain the consequence of decision. Here the doctor is advisor. That means he has given a decision, options, probably he has given his preference, you are going to take a choice. So this is, you are going to take a choice. This probably the one, probably many times at present people are taking this. So whether it's good or bad, that is his luck. Suppose if it is harmful, probably he is going to suffer. Next slide. So what is exactly this in summary? I decide you. This is paternalistic. In addition to I tell you my preference, if I give a fact and help you to find out your preference, interrupt you, and if informative is, I will give you a fact. This is what are 4 types of models of practice. Next slide. So what is the course of principles of dignity in patient care? What are the core principles? There are important 4 principles, core of dignity care. First is respect to autonomy. So this is enabling patient to take a choice, respecting the right to refuse care. It's nothing but when the person comes to you for a clinic and you advise some investigations, he may refuse. If he refuses, fine, it's okay, no problem. He can go outside and he can have his own choice. Suppose the person you are making he needs admission. Suppose he refusing it, no problem. Because if he refusing, yes, there are some people, they refuse a blood transfusion. Some castes usually they never take a blood. So you cannot say that you should take a blood, because that is its autonomy. Some patients probably they'll say, elderly people, what they exactly happen, aged person probably they'll say, do not resuscitate. Elderly people they'll say, yes, this person, end of life care. So probably they'll document. Sometimes people say, yes, you need admission. He refuses, yes, fine. So that should be documented. This is what called respect to the autonomy of patient. Okay, next one. Respect as a human being. This is what commonly happens in the doctor. Everyday day-to-day practice, we talk about this word usually. Acknowledging the unique history. So this is nothing but taking a history. It is eye-to-eye contact. You should have a history taking. Treat the patient with respect and avoid the treating them as a subject or bed number. So usually say typhoid, that bed number 4 has a typhoid. We should not talk. We should tell probably name. Bed number 6, patient has diabetes with diabetic foot. We should not talk like that. We should tell, respect the person, probably you should tell their name and probably you should tell. However, when they have some hidden disease, probably it's not safe to tell the name. Better to tell a bed number. For example, retroviral illness, hepatitis B, hepatitis C. Some diseases probably we may not able to tell the name. Probably you should say bed number. Next slide. Confidentiality and privacy. There are 2 things, physical and informal privacy. So this is physical privacy is very important when the people come to you. When you want to examine, putting the curtain, putting the cloth while examining, getting the permission from the patient is very, very essential. This is called physical privacy. Next one is informal privacy. This is nothing but when you document the history sheet, document the diagnosis. At the time of discharge, it is a right of a patient to keep it confidential. You cannot hand over this to family members because patient has a right to keep it secret. That's called informal privacy. Sometimes case sheets probably you should keep a password and you have to keep it inside. It is confidential. Somebody will ask you what is the diagnosis. Many times this is what happens, ICUs. Weekend they'll come, family members will come, what diagnosis, what is the outcome. We cannot reveal it because patient or the close family members, probably we should be able to tell the diagnosis. Next, empathy and compassion, providing the empathy care. It's very important to have empathy care these people, eye to eye contact, acknowledging their sufferings and pain, and during valuable or vulnerable or painful embarrassing situations, it's very important to get empathy care. Please, as we are discussing the previous session, AI is not going to give you this empathy care. Next slide. So in summary of these core principles, what we are going to do is patient involvement, personalized care, open communication, respect and compassion. These 4 important things you are going to give, that is called doctor-oriented, doctor-centered to patient-centered care. That means it is patient choice. What kind of care he wants. This is what you are talking about, patient-centered care. Beyond this, one more has come, that is called person-centered care. Person-centered care means in addition to this patient-centered care, you are going for his lifestyle modifications. Enter family you are counseling. That is called enter family you are going to tell about the patient's illness, how you can prevent the complications. For example, diabetes. You are going to tell the patient and family member to counsel him, control his sugars, probably the food care, eye care, all things to be done. That is what called patients to person-centered care. So this acknowledge the patient as a person with a life outside their illness. It's very important to get a patient-centered care. Nowadays we are going to do for patient-centered care. Next slide. In the summary of these last slides, medical illnesses, patient role is passive and patient role is active in patient-centered care. Patient is a recipient of treatment. Patient is a partner of treatment plan. And physician dominant in conversation. That means doctor has active role here. Physician collaborate with the patient. That means he is only give you opinion, patient has to take responsibility. Care in disease is centered, care quality is life centered. And physician does not matter, does most of the talking. Physician lies more, talk less. And patient may not adhere to the treatment plan. But with this patient-centered care, the adherence to the treatment and outcome is much better. Next slide. What are the patient's expectations? At present, what exactly they wanted from the doctor? Expertise opinion, be well informed and updated. That means patient wants updating their diagnosis daily or updating their condition daily. This is what they are expecting from the doctor. Accountability for answerable, so sorry if any mistakes. If it is probably the person has accountably answered. Suppose the person has done a blood test. Suppose it's come error. Probably you should talk to the patient, this blood test error is showing, we are going to repeat it. Sorry. That's very important to tell the patient. Respect their desired timing. Suppose you are given appointment for 3 o'clock afternoon, but you are held up with some meetings. You have come at 4 o'clock. First answer should be told to patient is sorry. Because that's very, very important. Respect them. Professional look out the patient's best interest. So you have to patient-centered approach. You should tell the patient, these are the best options are available. You take a call. That's very important to tell professionalism. High level of professional skills and professionalism is very, very important. Transparency, no unnecessary tests and referrals. This is what commonly happens nowadays day-to-day practice. Unnecessary medications, unnecessary referrals, if you see the medicines will be 1 or 2 and multivitamins will be 100. This is what going to happen. This should not be happen. This is what patient is expecting from a good doctor, only the limited medicines, what is needed for him. And treat them as an intelligent human being. It's very important to tell them, yes, I'm treating you as a human being, because they'll think that if you tell them, Mr. X, this is what disease is there, and you come after 1 month, they don't respect you. They think that doctor is okay making money. No, you have to tell them, yes, this is what your disease, you need to come follow up, and this is what is medications, these are side effect of medications, these are likely to have a complications. Whether you stay here or any other referral center, other place you go, probably needs a follow up. You tell them, they will understand much better. Next slide. What doctors expect from the patient? This is what important. Deal with the doctor with respect. Because the negative image of doctor, they think that yes, every doctor is making money. No, it is respecting a doctor is very important, because he will be having a lot of commitments. For example, you see public sector, if the doctor is there, he will come morning, he will attend the rounds, probably he will get some postmortem cases. The postmortem is the first thing right to be done immediately when the patient comes. Patient will be having big crowd, will be in the OPDs. Then after that, probably somebody will call, some meeting will be there, patient will be waiting. So he should understand that very, very important, doctors having some appointments. He should understand that because it's not in our control. Next is say thank you. Thank you when everything goes well, thank you. And realistic expectation from the patient. I'll tell you, at present I have 94 years female, urinary tract infection 3 times. She is on high flow oxygen. Patient party wanted still aggressive treatment. Already I have given a palliative care, DNR certification already they signed. Still they wanted a acute care. You cannot expect something beyond, you cannot do any magic for this patient. So we are treated and we explained every daily, updating the documents. This is not the only thing we can have because they cannot expect a lot of things from the patient doctors. See, already 94-year multiple urinary tract infection on oxygen, we cannot shift anywhere ICU because all the things are not possible to do for aggressive treatment. Unfair blame to the doctor unless anytime is there any problem. Unfairly blame because see the person sometimes happens suddenly pulmonary embolism. See, I tell sometimes medical terminology. If you have any doubt about this terminology, please ask me, stand and ask me. Sometimes some of the diseases like pulmonary embolism, sudden cardiac death, suddenly they'll develop breathlessness, suddenly acute myocardial infarction. These are likely to happen inside the hospital or outside the hospital. When doctor discuss these things, the patient or family member, they should accept it because he may be having risk factor. So this is what, when they expect these things likely to happen, initially they may tell, or if they tell, probably this is the reason the patient developed, they should accept it and pay them professional fees promptly and gracefully. Next slide. Violating the dignified care by doctor. What are the things? So what is going to happen? They have a lot of psychological stress. That is what increase anxiety, depression, loss of will to live, and lastly reduced adherence to treatment. So this is what the most important thing that will happen. They may not follow the drugs. They may not follow your follow-ups. Next slide. What are the barriers for a dignity? What are the things? Time constraint, heavy workload of doctor. It is what a most important thing. It is going to create problem for patients. Overworked doctor. Staff attitude, very arrogant attitude of staff nurses or receptionists. Probably patients will be unhappy. Systemic issues, especially privacy for a patients are not there. Inappropriate communication gap. This is very important tool to discuss patient family members communications. Privacy violation, this is you are talking about mainly the privacy of documents. Ignore the preference. This very commonly happens. Elderly people comes, pregnant patient comes, they expecting they should follow the queue. Other people think that they should follow the queue. It is not so. Usually they'll give a preference for pregnancy, those who are having kid or those who are lactating mothers, they give a preference. But ignoring the preference is also wrong and violating the autonomy. Not listening to the doctor, not listening to, patients. They are like a boss, they are ordering the treatment and just go and come back. It's wrong thing. These are the barriers for dignity of doctor-patient relationship. Next slide. Strategies for uploading the dignity. What are the strategies? Doctors, what they can do it. Next slide. Respect the personhood, effective communications, autonomy and decision making, privacy and personal space, compassionate care, empowerment. These are the important things doctor can practice in practice. What matters to approach? It's very, very nice word. Anybody can guess? I think I heard some psychology students are there. What is this? What matters to approach? Understanding the preference of patients, their culture, beliefs, values, all these things you are analyzing preference and tailoring their preference. So probably they want to go home. Suppose this, I told you 94 years patient is there. She says, I want to go home and die. I want to go home and see my grandchildren. Yes, that's your preference. You have to do it. That's what called what matrix you approach. It's because that is what their goal. Next slide. Role of patients. Next slide. Articulating needs and seeking involvement. Active participation during the decision making and patient care is very, very essential, and this is what needs a providing the feedback to the institution or hospital or doctor. It may be in the online or it may be in the hospital. It's because most of the NABH hospital they'll have feedback. If the feedback is that they can improve themselves. Next slide. What is the consequence of dignified care? What all things are going to happen if you give a dignified care to the patient? Next slide. Improve the recovery of patient, increase trust and enhance satisfaction, improved emotional and comfort. All this going to happen to the patient. So the follow-up will be better, treatment will be better, outcome will be better. Next slide. What is the summary of whatever I told you last few minutes? Doctor-patient relation, a delicate balance between clinical competence and compassionate care. Dignity is not a soft skill, it is a professional standard. And uphold the dignity of doctor-patient relationship, continuous practice rather than static goal. And uphold the dignity of clinical practice directly impact health outcome and patient safety. Upholding the dignity is not an optional courtesy but moral duty and act as a fundamental foundation of healing. Dignity of doctor-patient relationship is a silent medicine. It may not be written as a prescription pad, but it is often what determines the success of healing journey. That means very important to have a doctor-patient relationship, and uphold the dignity improves the patient's outcome. The trust between doctor and patient will be maintained well. Next slide. So this is what William Osler said in 19th century. Good physician treat the disease, the great physician treat the patient who has a disease. This is in 19th century he said. I think still we follow this word in India, but I think it's probably people awareness about the disease, probably health sector, doctor, community, society, all should aware about the stress what doctor is going. I think it need some time, especially complicated diseases, need some time to make a diagnosis. Its mutual respect is very important. I think I'll end the last slide. Thank you.
Thank you, sir, for that insightful address. The session is now open to questions. However, please keep your questions brief and short. We may not be able to take a lot of questions, but a couple of them.
I'm sure a few questions will be there. Yes, doctor. Deliberative and interpretive. Informative model is always best. Informative model, because you are giving an option to the patient. It is a patient-centered approach. You give informative model, and with that, at present scenario, better to give informative model. Options are available for them. They can choose, and they can go and discuss with the family members, or they consult a second opinion. They come back to you. That's very, very important, because their world is probably they can go and come back to you, because they'll get more confidence. When you tell options are available, they get more confidence of the doctor.
So they were pushed to a dilapidated building, and they're all on the floor, nearly 50 of them, too close to each other with IV in their arms. It was very disheartening to see, though we speak so much about the healthcare system and technology in India, it is so disheartening to know that one of the leading hospitals in Delhi, this is happening. And we talk so much about dignity to patients. So where is the dignity? This is happening in the leading hospitals. So what about other hospitals? What is the position of those hospitals and the dignity given to patients? And how do we go about tackling this problem?
No, see, there are two sectors. One is the private sector, one is the government sector. Private sector, definitely they can look at this dignity of the patients, because they see appointment based, only few patients will available. But if the person has attending the private government sectors, probably I think communication is very, very important. And priority based. Suppose the person is acute stroke comes, acute myocardial infarction comes. Communication with the patient or family member to try this patient early to the emergency. Suppose other patients, those who are probably may not be given a priority, probably they can give appointment and they can call them. Because attending the patient is very, very important. I agree with your crowd. In the public, especially government hospitals, the crowd is too much. Probably somebody can attend the case. I agree with, it's very, very difficult, but at least we can try some communication with the patient or family member. This is what happened. They'll be happy with that. Somebody will be attending. And suppose this patient is a crucial, because doctor can assess which patient is sick, which patient is stable. At least they can try that. If a stable patient, yes, they can tell, yes, these are things happening. So probably you can wait for at least half day, or probably come tomorrow, and probably you can give the appointment for them. Otherwise, I agree, it's very difficult, because I am standing other side. So I am in the corporate sector. Probably this is very easy to tell, but in the government sector, it's very, very difficult. As I told you, morning he'll come for postmortem, after that he'll go to OT, and OPD patients will be waiting, they'll be shouting at him, evening meeting will be there. It's not possible a doctor to attend any cases. Sometimes we may not able to attend not even one case per day, and we'll do biometric attendance, morning to evening. It's not possible. But sometime definitely you can explain the patient part, yes, I'm not available, or I'm sending my assistant. It's fair enough. At least they'll have some trust. Yes, doctor is told something, so at least he'll come tomorrow, or he'll give an appointment tomorrow afternoon.
Thank you, sir.
Thank you, sir, for the prompt responses. I would like to request our trustee, Madam Pallavi Dempo, to present a memento to Dr. Shiv Shankar as our token of appreciation.
Thank you, madam. Thank you, madam. Thank you, madam. Thank you, madam. Oh, sorry.
Dear colleagues, we will now begin with our next plenary session. In fact, this session is very special because it features two of our very distinguished speakers, Professor Gayatri Prabhu and Professor Nikhil Govind. I will be introducing both of them, and we would like to welcome them. Professor Prabhu, of course, will be delivering her plenary first, followed by Nikhil Govind, but I would like him to be on the days as well. It is my great privilege to introduce Professor Gayatri Prabhu to you all. In fact, as I mentioned to her, I think I manifested this plenary way back in 2025 when I exchanged an email conversation with her on another topic altogether. So it's my privilege to tell you that she is a professor of literary studies and the director of Manipal Institute of Social Sciences, Humanities and Arts at the Manipal Academy of Higher Education. She's also the coordinator of the Student Support Center, a mental health resource for students in the campus town of Manipal. She holds a PhD in English from the University of Nebraska-Lincoln, USA, and MPhil in creative writing from Swansea University, Wales, the UK. She was awarded the R.K. Narayan Award by the Booksellers and Publishers Association of South India and the Charles Wallace Writing Fellowship at the University of Stirling, Scotland. Alongside articles in leading international journals and edited volumes, she is the author of 8 books in varied genres. I have had the privilege of reading most of them, including 4 novels, Vetal and Vikram, The Untitled, Bird Swim, Fish Fly, and Maya, a memoir titled If I Had to Tell It Again, which is a must-read for all of us, a novella in prose poetry titled Love in 7 Easy Steps, and a study of black and white Hindi cinema titled Shadowcraft, Visual Aesthetics of Black and White Hindi Cinema, which she has authored with alongside Professor Govind. Her recent work, titled A Genre of Her Own, is a study of life narratives and feminist literary beginnings in modern India and was published by Bloomsbury in 2025. I request Dr. Svetlana Fernandez to welcome Professor Prabhu to this plenary. Thank you, ma'am, for being here. Her plenary is titled The Doctor and the Princess, Historical Life Narratives of Healthcare and Motherhood in India. I would also like to, ma'am, if you could just please take your seat on the dais. I would also love to introduce Professor Nikhil Govind to our audience. He's a professor in literary studies at the Manipal Institute of Social Sciences, Humanities and Arts. He is also the author of The Moral Imagination of the Mahabharata, Shadowcraft, as I mentioned, which has been again authored with Professor Prabhu. Inlays of subjectivity, affect and action in modern Indian literature, and Between Love and Freedom, the revolutionary in the Hindi novel. He is also a working editor at the Indian Journal of Medical Ethics and brings with him a vast pool of experience and expertise on this topic. I request Dr. Svetlana to welcome Professor Govind as well. His plenary is titled The Literary Memoir and the Idea of Mental Health. May I request Professor Govind also to join us on the dais, and I request Professor Prabhu to take over her plenary with a fascinating title.
Namaste. Many thanks to the organizers and sponsors of the conference for your very warm and generous hospitality, especially to Dr. Akshata Bhatt for the invitation, the manifestation. Professor Nikhil Govind and I have been colleagues for well over a decade. During this time, we have co-taught, co-written, but even though both of us have been working on health humanities in different ways, this is the first time we are sharing a session on the subject, so thank you for that. Today we decided we'll both discuss life narratives through perspectives and methodologies that we draw from our discipline of literary studies. And we are also, both of us, we just discussed that we are well aware that we stand between you and lunch. So we'll try and we'll try and stick to time, okay? So I'm looking at my clock. Right, so this is, like we said, we discussed that both of us will address lived experiences. The centrality, importance, weight of life narratives and lived experiences in matters relating to health, well-being, illness, mortality is now very well established and well accepted in the field of health humanities. Indeed, your conference concept note also foregrounds it. So rather than any sort of hierarchical biomedical constructs or the pathologized sort of approach, it is the first-person narrative that helps us place the human condition at the center, thus inviting, in the words of Arthur Kleinman, to partake in a quest for a kind of human wisdom, a model of forbearance and courage, a form of goodness, a lesson in the essentials of humanity. So like you were told, I titled my talk today as The Doctor and the Princess, Historical Life Narratives of Healthcare and Motherhood in India. The doctor is Haimabati Sen and the princess is Suniti Devi. Both these women feature in the concluding pages of my recently published book, A Genre of One's Own. So in this book, I've attempted to trace a feminist literary genealogy through life narratives by women in late 19th and early 20th century India. The final structure of the book, however, did not give me enough room to study these writers in detail, and so this felt like a good time and good company to revisit them, but from a health humanities perspective. I'm also assuming that I'm likely a minority in this conference who's going to be focusing on historical figures and texts from like 100 years ago. Hence, it would be fair for you to ask, how might historical life narratives or lived experiences of health by women who wrote in the early 20th century help us make sense of contemporary healthcare systems, healthcare practices, indeed, health humanities as a critical academic orientation. So I request you to, let's put a pin on the question. I will return to it at the end of this talk. So both Suniti Devi and Haimabati Sen are exact contemporaries from the Bengal region. Suniti Devi was born in 1861 and lived for 68 years till 1932. Haimabati Sen is 2 years younger and then lives a year longer than Suniti Devi. Suniti Devi was the daughter of a celebrated social reformer, Keshav Chandra Sen, who's noted for his Brahma Samaj activities, and she was married to a prince, the heir of the princely state of Kuch Bihar. She had access to education, material comforts, and made several trips to Europe. In 1921, at the age of 57, she published her memoirs with the title The Autobiography of an Indian Princess. I brought both books with me in case you want to look at it during the lunch hour. And also, if you want to have a look at them, there are many pictures of her. This you can see on the cover is a very stately, in all her royal fineries. That's on the cover. So hence the autobiography of a princess. Haimabati Sen, on the other hand, her life could not be more different than Suniti Devi. She was born in rural Bengal in a family spiraling from, like they were landed gentry into penury. The hardships endured and recorded by Haimabati Sen are tremendous. An early marriage and widowhood, second marriage of great discord, including physical abuse, raising children as a single mother, sexual harassment and marginalization in her professional role, persistent financial woes, even as she takes philanthropic responsibilities for orphans, widows, and several illnesses leading to blindness. The notebooks she filled with her recollections were hidden for over 80 years and only published in early 21st century entirely by chance. Okay, so there are not many pictures of her, and we have one here. This was translated by Tapan Rai Chowdhury, and Geraldine Forbes has written an introduction. So we have two life narratives, and as pointed out, the circumstances of the authors are in stark contrast. I invite us to approach them in the following ways through the experience and trope of motherhood. Suniti Devi's life as the daughter of a prominent reformer and wife of a ruler of a princely state, while being privileged in a very obvious sense, equally speaks to the truth of an unbearable entanglement with bereavement. So I'll talk more about it, which is the death of an adult son. And this surfaces in new and potent narratological terms. Haimabati Sen has a hard-fought journey as a professional woman in medicine, and this may be better appreciated, I'd like to suggest, in the light of her devastating critique of the Indian family, where often the rhetoric of idealized motherhood is employed to normativize the exploitation of a earning member. The preoccupation with the mother identity for both writers, I think, should also be seen in the light of the centrality of maternal health to medical discourse of the late 19th century. The only time a woman appeared to the medical establishment was in this context of maternal health, health of her child. There is very little sense of a woman's health post her childbearing years or without reference to children, youth. Whenever women were trained for the health establishment, it was always as a support for women and child health, since maternal and infant mortality was very high, and there was some reluctance to call the male doctors. So what I'm suggesting is parallel to a very public health discourse of maternal health and mothers, there's this other private vein that I'm trying to tease out. Haimabati Sen's journey into the medical profession was more unusual than most. She was married at 9.5 years to a 45-year-old widowed man with 2 daughters her age. He dies within a year of her marriage, leaving her a child widow, an incredibly oppressive social situation at her time. She forged ahead on her own courage, resources, moved places, took up any odd job that came her way, truly formidable. And then at the age of 23, is persuaded to marry a Brahmo missionary. Around this time, a new experiment for medical education was launched for women in Bengal. The Director of Public Instruction offered scholarships for women to join a 3-year course at the Campbell Medical School in Calcutta. Okay, so this was 1891, and at that point she was 26 years of age. So to again give you a little bit of context, it's about 7 years since Kadambini Ganguly, 1881, became the first woman to be admitted to the college. And at this point, it was mostly Europeans and Eurasian women who were having access to the education at all, if at all. So they had to have formal education to qualify. What Haimabati Sen has, like a smattering of education very young in her childhood that she's heard, and then some amount of self-learning. So what we have is a parallel vernacular program that is introduced so that more women can qualify for medical degrees, but the degrees, again, it's hierarchy, it's not given enough respect, right? And there's a lot of struggle for legitimacy, respect, and employment. Now, Haimabati's hard-fought education, which she had to do while running her household and having children, we should also note she topped her class. She actually was deserving of the gold medal. It was denied because all her male classmates went on strike. Employment was even more difficult. When she finally did land a low-paying job in rural Bengal, she was sexually harassed, physically assaulted, all of which she records. Like, it's quite a stunning autobiography. I invite you to read it. The fact that she chronicles it as she does without mincing words. And when she finally does land, even as she's doing this, she has to deal with a very unsupportive husband and raising 5 children on her own pretty much. Then for years, we have to note that her work as a medical professional is undermined, unpaid, unacknowledged. But as she persists, she starts to write her life experiences in a notebook around 1923-21, and then she dies in 1933. We know that she was diagnosed with breast cancer as well during these years. Now what happens is these notebooks are forgotten or suppressed. It was a scathing narrative of family betrayals, so you can understand why. And it was finally published in 2000 when a descendant happens to hand it over to Geraldine Forbes, who's a historian who specializes in women's movement in India. Forbes notes the text's intimacy and directness of tone and attention to detail. In fact, she calls it, I quote her, the most detailed personal narrative so far uncovered, which has a bearing on the lives of Indian women born in the 19th century, right? And however, we must note that perhaps the dual identities of a professionally qualified woman with a full-time career and also a writer who's very outspoken about their rare accomplishments actually pretty much led to a near obliteration of the first-person narrative in the case of Haimabati Sen. So while we acknowledge that it's not cast in a rhetoric of rights and citizenship, right, in the way that we identify it now, her life narrative becomes an active participant in the construction of what can only be considered as a feminist archive. By virtue of its exposing narrative affects typically disdained and suppressed by the image of quote-unquote the good reformer woman, right, like as Sarojini Naidu might have been considered at that time. Such an archive, and this is the argument in my book, permits us to catalog unbridled emotions that women were usually discouraged from expressing against family, right? For example, jealousy, outrage, abandonment, resentment, libidinal cravings, disinterest, disgust, disagreement, right? The fact that these turn up, and today I'm trying to also see it in the health humanities frame, and I want to see what that looks like. So, even in sections where the author, who repeatedly emphasizes her gendered position, chooses to cast her life in a language of gratitude, even when she does that, the archive invites us as readers to read against the grain. The distinguishing feature is unrelenting bluntness. What she experiences, how she feels, is closely fused with candor, particularly the ingratitude of her children. Right? The closing pages is an inventory of grievances against the children, a rare moment in literature, in sort of the Indian literary tradition of dissecting motherhood as often unrelenting, thankless, and exploitative. I'll read you from her own words. I avoid both close relationships and quarrels with people. Meanwhile, a number of things happened which lowered me in the esteem of people. The harassment I suffered at the hands of my intelligent sons and daughters on this account was in no way insignificant. No matter how much I looked after my family with care, the world did not fail to persecute me. My children oppressed me to an extraordinary degree, even though I had done nothing wrong. The writer's dilemma is about what can be shared. Public, legal matters demand delicacy, and yet family betrayals need exposure. We note that the public service in the hospital is the only moral counterpoint that is afforded to Haimabati Sen at this time. Okay, and I'll read a line that she says. I realized the human heart did not attain peace through the performance of duty in return for pay. Right? She writes repeatedly, explicitly, of her struggle to reconcile endless demands of caretaking on a doctor, on a mother. On the other hand is the rhetoric of duty, which the word she uses is charity. I don't know what the Bengali word is. English translation is charity. And there's this stark injustice of caregiving that is unacknowledged, unreciprocated, and poorly remunerated. I'm wondering whether Haimabati Sen is referring to medical ethics as well when she uses the word charity. There's no greater virtue, she says, and calls it the one tender impulse in our heart, right? And then she says, women have no freedom. There's a limit to charity. So this tension between the personal and professional duties, especially through the rhetoric of motherhood, is what we will encounter in the narrative of our second writer. And so we turn to Suniti Devi. So Suniti Devi's The Autobiography of an Indian Princess, which is published in 1921, attests to the author's accent on a public role, perhaps even a slightly exoticized one, because much of it is for readers in England, as it may be an educated class in India. It was written in English, so not translated. And yet, the more substantial moving part of the book actually lies in the domestic, the intimate, particularly when the princess speaks as a mother. This maps an entirely parallel affective topography, wherein the textual sort of dethronement of the poised, successful princess is to be found in chapters about death, first of her husband, then two adult sons. Grief performs not only as the leveler, so like the idea of the royalty and commoner, but in causing the steep fall from what is publicly considered as good fortune, rendering the princess wretched and isolated in her pain. So like I said earlier, she's born the daughter of a leading public intellectual of Bengal, Keshab Chandra Sen. She's married to the Prince of Coach Bihar. She's educated, observant participant of an elite social echelon. The autobiography speaks of a very idyllic childhood, celebrated controversial marriage. It was controversial because Keshab Chandra went on about, the right age at which girls should be married, but married his own daughter underage, as did Rabindranath Tagore. But, there was a controversy, public outrage. She calls her husband fairy tale prince of my romance. That is her word, not mine. And then soon after, she writes about how absolute he was in his control. I'm quoting her. He had the strictest ideas about my conforming to his ideals. He did not like loud laughter, loud talking. I was not allowed to ride, dance, play tennis. He decided what she wore, stuff like that. But large sections of the autobiography is given to her duties as a princess, detailed notes, right? International travels, social engagement, who's who in Europe, all the royalty she's meeting. It's a very cosmopolitan network. But soon, it's almost the gravitational pull of the text is towards a central sort of strand of suffering and endurance. One might even think of it as a very meditative dialogue with death. Okay, so first with the passing of the husband, this is what she writes, I quote her. Timely or untimely, and time untimely is a repetitive trope here. Death had come, timely or untimely, death had come. He did not heed the anguish of my heart. He did not hear my cry, nor see my tears. He carried away my dear one and left behind. Okay, so that's the first note, and then it starts to build like a crescendo. Soon after her 31-year-old son, the firstborn prince, Raja Rajendra, dies. And here, even her identification with Queen Alexandra, who's the Queen of England, is through patterns of grief. So she writes a letter to the Queen. I'll quote the letter, few lines. Fate has dealt heavily with us both. We have each lost our idealized firstborn. We have each lost the best of husbands. We have equally sorrowed. The sorrowing that dominates the second half of the autobiography completely eclipses the glittering social triumph that she presents with pride in the first half. All the wealth, all the influence, all the treatments, best doctors in the world, France, London, India, cannot extend the life of her son. She chronicles his health difficulties, starting from a fall from a horse while playing polo in France. Then, of course, he's moved to London. And the health troubles continues, but and so does he, return to a repeated prophecy of his life, where astrologers could not see his life beyond 31. Like, they could not predict after 32 there was, so he expected to die at 32. And then she has conversations with her son on death, which she records. And this is what he tells her. I may be young, he tells her, but if God sends for me, you must believe, mother, that it is a timely death. right? And as she writes of the days leading to his death, he talks to her, the irony of the name she's given him, Raja Rajendra, right? She says, "You know, mother, even the king of kings must die." One sees the shift of her language from the princess persona to the mother whose pain cannot be contained. The sentences spiral into visceral mourning. I'll read those sentences. 31 years ago, this boy had brought me every possible happiness. Now the world is dark and gloomy, and I do not know how I shall travel the last part of my journey. So heavy laden am I with grief. What remained for me? I had to suffer the long days and the misery of the hours when sleep forsook me, and grief kept a watch by my pillow. I had to live and think that to live is sometimes the worst torture that is inflicted upon mankind. The rest of the autobiography persists with more records of the author's social responsibilities, but is never able to retrace that initial narrative orientation of being a chosen one, a princess, right? And that is the note even as she has to endure the death of another adult son. She says, "My love is so strong that I think death has opened the door of eternity a little way for me. My dear ones are nearer to me than ever." So grieving is now the only companion for the aging princess. She resolves that its company, like the company of grief, can be counterbalanced only through love and public service. Okay, so this is a theme we have already noted at the end of Haimabati's sense notebook, right? So there is this personal suffering, sacrifice, and then what is the counterbalance? Is it public service? Which brings me back to the question I had raised, so I'm wrapping up here. The question that I had raised at the start, which is how might historical narratives or experiences of health by women who wrote in early 20th century help us make sense of like contemporary healthcare systems, healthcare practices, or indeed health humanities as a critical academic orientation. Okay, firstly, there is a strong socio-historical context that is also self-consciously gendered, in that the writers talk about women, the writers talk about themselves being women in very specific social mores, right? In paying close attention to the multiple tonalities of these tellings, we are able to learn more about the antecedents to healthcare in India, the continuities as well as the ruptures, right? Thus, one must learn that one can never separate the person from the so-called health professional. And indeed, the more the professional can draw from the personal, the greater might be their empathetic skill. Secondly, we notice that applying interpretative skills to life narratives is a core skill and transferable, right? This is how the very field of medical humanities was led either by the discipline of history or then, of course, my discipline, literary studies, right? That listening to life narratives or interpreting what we hear, right? It trains us to continue to foreground the human condition in our study of health and healthcare. Thus, even if one is looking through the lens not of the rarer health professional, but the role more common to most of us, right, the person in need of care, then we realize even more pointedly that ideals of health can never be separated from our larger mortal, death, illness-stricken humanity. To pretend otherwise is to live in avoidant and poor mental health. Equally, it helps us understand why the ethical dimension is deeply embedded in any listening that is informed by the principles of health humanities. As the scholar Robert Coles reminds us, cognition, not impulse, produces emotions, and attending to nuances in literary texts, especially life narratives, deepen moral sensibilities and ethical reflection. Thank you for your time and patience. Now over to Nikhil.
Okay, hello. Yeah, so I'm very aware that I'm the last man standing between you and lunch. And so I will actually keep this brief. And I think Gayatri's work has sort of helped me segue, somewhat sensibly into this. So I'm just going to really be talking about one particular work. And this is a memoir that came out now almost a decade ago. It's by a woman called Reshma Velyappan. It's called Fallen Standing. And it's a memoir on actually being a schizophrenic, which is, of all the medical conditions, even in the legal system, legally this is the only recognized quote-unquote madness, right? It's very complicated because the mental health and the legal discourses in India have really poorly aligned. There's a very fine dissertation by one of my colleagues in the National Law School who's discussed you can only divorce your partner if they are schizophrenic, for example. So it's a very complicated sort of terrain. I can only sort of indicate it, and I think there are many kinds of studies one can do within health humanities, within mental health humanities. You can almost go disorder by disorder, and each of them track differently. So I'm just going to explore this because even though as humanities scholars we are always trying to make ourselves relevant for policy and make ourselves relevant for something like this, I think the richest strand of, say, psychological, psychoanalytic thought that has helped the field is just a kind of affirmation of the lives these people lead, right? I think beyond saying, okay, this will improve health policy or this will improve outcomes, and one tries to do that, and that tries to be a good citizen on it. But I think ultimately it's about what is the nature of like the full potential of human nature, and to be really inclusive beyond it being like just a cliche term that one uses or overuses. How does one really affirm a life that is actually that extraordinarily difficult? So something like schizophrenia is, and almost like the Himalayan peaks of real distress and difficulty, and yet how is one also able to read this in this extraordinarily affirmative way, in a way that really says, okay, this is what really being inclusive means, right? And of course, this is part of a larger book that I've written. It's called Inlays of Subjectivity. It was mentioned. It's an Oxford book from some time ago. And I do connect it to other kinds of self-narrativization. So for example, how does a health identity equate with being, say, a Dalit identity or other kinds of disadvantage? Again, a very complicated terrain, which I'm not going to go into, different kinds of ideas of disability and ability. So here, it's called Fallen Standing. It's got her face on the cover. And so it's a way of being like, how does someone present publicly when you've got these kinds of issues? So this, from sexuality studies, you have the idea of coming out, but now people come out as Dalit, people come out as, in this case, my life is a schizophrenic, in quotes, is the subtitle. So this is an extraordinary kind of way of being public. It's not just the public in the way like we are in a public sort of space, but here actually to get to a point of the public, because now you can't unsay it, it's now there in the world, right? So it is a decision that maybe she regrets today, but it is already an act of great courage. It is already sort of, enlarging our world, right? So I just want to talk about what is our notions of post-colonial citizenship, for example. What is our understanding of, say, suffering, right? There's among the many sort of deficits we're happy to point out about the regular healthcare system. We've known that mental health has always been somehow not achieved parity of physical health. It isn't as intuitive as, a broken leg or something like that, right? So it has to present itself already in a somewhat defensive kind of way. So for me, I'm also paying attention as a primarily a literary scholar, so I'm aware that it's autobiography, it's memoir, it's just a sort of account. And I'm just looking at what it takes for her to say this, right? Not just to celebrate her courage, but to celebrate then what kind of world we live in, right? So she cannot know whom she's addressing, so that obviously she's addressing a much larger body of people than people with schizophrenia, right? And so there is this huge gap between speaker and reader. It is not like a book one can pick up and say, okay, I've read a book about, now I know something about Spain because I've read a Spanish novelist, right? It doesn't work like that. And I can see, and I've also think about this often in pedagogical contexts. So, for example, recently I was teaching, there's an anthropologist from Princeton called Emily Martin, and she's actually a sinologist, she studies China, and then she had effectively a kind of psychotic break. And then the second book became more an ethnography of bipolar disorder, and it's called Bipolar Expeditions. which is, a clever pun. And she talks about, mania and depression, and like a lot of other scholars like K. Redfield James and all of that, she prefers the manic depression terminology to bipolar, and because they feel like it reflects experience better. So I was teaching this in a class of mine, and we were having a very good discussion for a very long time. But then suddenly somebody just put their hand up, and a woman said that actually I've been diagnosed with this. And after that, the whole class conversation just fell a whole notch, because after that, nobody felt that they have the authority to speak about this, right? So I think it is a lot about the ethics, is also classroom ethics. It is about like spaces. It is about who has the right to speak and when, and then of course people have a right to silence. People have a right to sort of respect. So after that, it was a hard class too, so I kind of wound up early also. So these are all the sorts of questions that we talk about when we talk about sort of mental health. It's not just something at a diagnostic sort of, level. It's in the classroom, it's pervasive. We have, we teach in colleges, so the 18 to 25 age group is extraordinarily vulnerable to mental health issues. We know that. There are lots of problems around disclosure. There are lots of shame around it, lots of these things. So it's very extraordinary when we have memoirs that actually talk about this, and this is an extraordinary sort of memoir, right? I'll just take out a few sort of letters so that you get a flavor of the book, and I will say why this idea of doubt, of the self-doubt of presentation, is also very important. Because it's sometimes identity we can become very assertive about identity, and there are certain forums, political forums, advocacy forums, where it's important to just say, I'm X, this is my disadvantage, and I claim my right, and the very hyperbolic language of rights and citizenship, where, but I also want to draw attention to many other spaces where actually it's full of shame. There's lots of hesitancy, there's lots of difficulty, there's lots of extra fear of being hurt. Not all disadvantages is on the same playing field, etc., right? So this is something about, this is a quote from her just so that you get a flavor of the book. I learned more about my label, schizophrenia. I accepted it. I continue living with it. Then again, today I get remarks like, you don't look schizophrenic. I wonder again, what does a schizophrenic look like? It reminds me of the case of a woman with cerebral palsy who was offloaded from a flight because she looked mentally ill. Is this what the world thinks of the mentally ill? Do we have it printed on our foreheads? Lunatic? They have denied me the most basic fundamental rights of the Constitution of India. This is also important, the idea of sound mind. There's a lot of good legal scholarship on the idea of you have to be of sound mind to stand for election, to vote, things like that, right? They have denied me the basic fundamental rights of the Constitution. They have taken away my legal capacity by a simple label. I cannot vote. I cannot sign a contract. I cannot hold office. I have no right to the same education. I have no say in my treatment. I can be held against my own will, but I have to pay taxes, right? So you can see how this sort of language, she's very aware. She's also a diasporic kind of Indian, Malaysia, India, all of that, right? So, there are, the writing has to perform the difficulty of the situation, right? She can't just say it in the way a doctor is saying it, like, because then she'd be sounding like her own doctor, and she wants to sound like herself. So there are lots of the writing performs it. There are ascents, descents. There are lots of shifting moods. There's anger. There's reticence. There's indecision. But in essence, the language, though it's riven in pain, is inviting, actually, which is, I think, the extraordinary achievement of the book. Is inviting, is hospitable, and it's always searching for that kind of empathetic reader, somebody who will learn to listen, right? It insists that if you really listen, this truth-telling is more important than anything else you have listened to in your life. It is a primary duty, right? And is the primary duty, but this is a Greek concept, courageous speech. I'll skip the thinking about it, but for those who are familiar, it was important in Foucault's last works, for example. It's not ultimately beholden to the listener or even to the speaker. Language is its own gift and pleasure, as is truth, meaningfulness, body, endurance, the skein of I and the self, right? So Valyapin writes, and my existential question, who am I, is replaced by the what the world thinks of me, what are you, right? That is the sort of diagnostic label. And the world's lack of listening is accompanied by its constitutional refusal to grant legal moral authority, as I've sort of said, right? What is being lost in our refusal to hear the courageous, even if chaotic voices of these speakers who are inventing a whole ethos of new freedom? So these are questions about where, instead of life narratives, on the one hand, like I say, as health humanities, we feel like let's just tag it on to health policy, then the humanities are always anxious about not being relevant enough. But actually, if you take it the other way, it's about, this is the these are primary claims about human nature. This is a primary claim about what the fullness of citizenship is. These are the people we need to include in our ideas of a good life, right? And this is a very interesting book because it actually was not intended. I was talking about what it takes to write this, and actually it was not even meant to be a book. These were actually long emails written to a publisher, and they were discussing what kind of book to write and how to write this book. And finally, at some point, the publisher said, "You're so articulate about the meta of the book that has not yet been written that let's make that the book." And I think that also serves as something about like what language does in terms of, you know, we're not always sure beforehand what is the subject and what is the sort of meta reflection on the subject, right? So, so she talks about it, parts of the book, perhaps the episodes hardest to absorb for the protagonist are written in the third person. And that is also very telling because in schizophrenia, often you have this, right? Out of body, out of self, you're writing in the third person, you're outside, right? So she says, so sometimes she says, the she is not just unaccommodable, but actively one who is annoyed, hated, embarrassing. These are very difficult things to write about, right? To speak, and then you're forced to speak of yourself in the third person. And there's a lot of shame, it's a lot of family shame. Because of course, if you have someone like that in your family, then that becomes very hard, right? So in terms of the, you know, the lofty and wonderful themes of the conference, this is what I would say. What is dignity, really? Like, I mean, unless we're able to afford dignity to these kinds, and this is an extraordinary person who has written it. Of course, most people with, you know, most people don't write. And so, you know, how does one really enhance our idea of citizenship to really include these kinds of texts, right? For me, that would be really crucial. So, and now I will not take up any more of your time, so have a good lunch. I will speak on behalf of the organizers. But thank you very much for inviting me.
Since we are heading towards lunch, I think Professor Prabhu and Professor Govind expressed that any questions they would like to take during the lunch time so that they don't eat into that hour. However, I would like to convey my sincere gratitude to both of them for actually bringing one of the core ideas of health humanities, and the way we thought about it from the literary perspective is also this concept of agency. Who is telling what stories, who's listening, and what do we make of it when it is ultimately published? What backgrounds do these writers come from, and why actually both of them spoke about auto-narratives, memoirs, autobiographical writing, which has become so crucial to the way we look at medical humanities today. So it is tied really beautifully with the keynote address and the first plenary